and welcome to the Bombay Orthopaedic Society Worldwide Webinars. I'm Dr. Gautam Zaveri, the President of the Bombay Orthopaedic Society, welcoming all the viewers and who are there, who have joined us online today to watch this very interesting webinar on a topic which is of current interest: unstable shoulders and stable decisions. Today's webinar is being done in collaboration with BOSTAA, and we have three very eminent panelists from UK and Europe, that is from Portugal. I will leave the introduction of the panelists to Dr. Prasad Bhagunde subsequently. Dr. Prasad Bhagunde is the convener for the show today, along with Dr. Ravi, Mr. Ravi Bhagunde, who is from the UK. Prasad is an orthopedic surgeon specializing in sports medicine, arthroscopic surgery, shoulder and knee surgery, and is attached to some of the premier hospitals in Mumbai. Shoulder and elbow surgery has taken a big leap, and the interest among delegates has surged over the last 2 years. And we find that a lot more people are interested in this today. With this in mind, the Bombay Orthopaedic Society has declared January 2026 as the Bombay Orthopaedic Society Shoulder and Elbow Focus Month. We start with today's program, which is the BOS Worldwide Webinar on this topic. And subsequently, later next week, from the 17th to the 23rd of January, we have got a very unique program called as the Bombay Orthopaedic Society Shoulder Elbow Course. It is a 1-week-long course during which delegates will be exposed to cadaveric surgery, sawbone workshops, real-life surgery symposiums, as well as attending the operating rooms with famous, well-known shoulder and elbow surgeons across Bombay. And this will be coupled with lectures, case discussions, etc. In a sense, a very comprehensive 1-week program in case you have an interest in shoulder elbow and want to further your career in that field. Finally, on 18th of January, which is the next Sunday, we have got a live shoulder elbow surgery symposium, which is going to be held at the Jupiter Hospital in Thane in Mumbai, where eminent surgeons are going to demonstrate between 12 to 14 shoulder and elbow surgeries of various types. I'm sure you will not want to miss this program. If you are in Bombay, you're welcome to join us at Jupiter. And if you're not, then this program is going to be telecast to 25 different cities across India. And I'm sure you can catch the program in one of these sessions. Without much ado, I would like to hand over the mic to the Secretary of the Bombay Orthopaedic Society, Dr. Ashish Phadnis, for giving us a little bit of insight into what the Bombay Orthopaedic Society is all about. Thank you.
Thank you very much, sir, and a warm welcome to all of you who have joined us, and a warm welcome to Dr. Rujuta Mehta also. So I just introduced the society for the benefit of viewers who are logged in, and it gives me great pleasure to welcome the BOSTAA delegates and Ravi, my dear friend, and the faculty from BOSTAA. We are a 60-year-old society, and this year we are celebrating 6 decades of our orthopedic existence and 6 decades of excellence. It all began in Bombay. Dr. R.J. Katrak was the first orthopedic surgeon in India, and he established the first orthopedic unit in the Wadia Children's Hospital. And since then, he established more teaching units in the KM Hospital and the Nair Hospital. He was the first Indian to be awarded the honorary fellowship of the British Orthopedic Association. Through its founding years, we had the benefit of true visionaries who laid down the foundation and laid down protocols for us to follow. They were academically inclined, and as they formed the society, there was a lot of clinical sort of interest, clinical teaching activity being done. We had bi-monthly clinical meetings to begin with. There was lecture programs, which was spread over 3 days. And slowly, it sort of, blossomed into a bigger entity, and where they had an annual conference, which was the YROC. It is a Western India Regional Orthopedic Conference, and it is a very prestigious meeting, the last edition of which was just concluded a couple of weeks back, where Dr. Gautam Zaveri was the organizing chairman, along with two organizing secretaries, Dr. Parag and Dr. Chasnal. YROC is quite prestigious for us. It is very close to our heart, and we are proud to say that it sort of is ranked very highly amongst all the academic meetings across medical specialties in the country, and it is one of the most premier orthopedic meetings in the country. Over the period of the next few decades, there was a rapid growth. There was a rapid clinical activity, with regular clinical meetings and master series being conducted. So the first Sunday of every month, we do have a clinical meeting where surgeons from all across the city, they meet. Regional faculties, they come. We discussed challenging clinical meetings. The first Sunday of the every alternate month, there is a master series where we pick up a topic in the interest of the general orthopedic surgeon, and that topic is thoroughly, thrashed out by key opinion leaders. We do conduct regular courses, basic and advanced courses in trauma, spine, arthroplasty, arthroscopy, and all the subspecialties of orthopedics, and do run a very vibrant and a well-attended postgraduate teaching program. Recently, we have also reignited our fellowship and observership programs, and we are in discussion with a few international organizations to send our members to their societies or visitation programs, and we do welcome people and delegates from the other societies to come and visit key opinion leaders in Bombay. We do run a journal. I'm proud to say that this journal is now indexed with the Scopus and the DOAJ. So this is a by two editions of this journal come every year, and we are seeing an increase in the submissions to this particular journal. It's a very progressive society. So we have had a protocols app. It's a consenting app for orthopedic surgeons. It's free to download for orthopedic surgeons worldwide. It has got a lot of surgical procedures along with the information where the surgeon can log in. He can put in the patient's name. He can have pictures onto the consent. And it's a comprehensive consent which is valid in a court of law, which the surgeon can just print out and hand it over to the patient, attach it in the patient's notes. It's free to download from the Apple Store or even from the Play Store. We have a sort of a corpus for basic science research, and our research, which has been performed over the few years, has had practice-changing implications, and it is very well received and very well published. Where do we stand today? We directly or indirectly influence more than a quarter, or I would say more than a third of practicing orthopedic surgeons across India. And this is just because we have had such a rich legacy of people and academicians who take a lot of interest in teaching. To extend this further in this year, we have had worldwide webinars, and these were conducted monthly. We have had outreach programs, and one of the outreach programs is happening in Ranchi as we speak, where Dr. Gautam Zaveri is there himself. And as he mentioned, we have real life surgery symposia. This year we did 4 of them. One was on hand. There's one on foot and ankle. There was shoulder and elbow, and there's one on pediatric orthopedics. This year, we released a series of 6 monographs on commonly encountered clinical problems. And the chief editor is again Dr. Gautam Zaveri. And these were distributed free of cost to all our delegates who had attended the recent VIROC. And this is an amazing piece of work. So these will sit in, this is a ready reckoner of what's current and what's latest in these particular topics. So to recapitulate, I mean, these worldwide webinars were the brainchild of Dr. Gautam Zaveri and Dr. Rujuta Mehta, who has, tirelessly liaised with orthopedic societies worldwide. And the screen will just show you, as I mentioned earlier, the Canadian Pediatric Orthopedic Society, the Bone and Joint Journal, Asia Pacific Orthopedic Association, the Foot and Ankle section, the World Association of Infection, Orthopedics and Traumatology, various hand societies, British Association of Spine Surgeons, the British Hip Society, and today we have the BOSTAA. So these webinars are quite successful. They're watched by a lot of our members of the partnering societies, and they keep on garnering a lot of views. So we hope that this information and this teaching is sort of propagated. Having said that, our next big event, and which is going to be the WIROC 2026 in December, and I'm quite pleased to invite all of you for that next year's event. We'll be looking forward to an active participation from BOSTAA as well. Ravi, you must come here. And Jayesh Baviskar, who's logged in, who is our executive committee member and who is liaising for all these webinars, who's logged in as well. I welcome you all on behalf of all our members, and we look forward to see you in WIROC. So with that, I would hand it over to Dr. Rujuta Mehta, and we would start the webinar. Thank you very much.
Thank you, Ashish. I think it's been a very enjoyable journey all through. It was actually all Gautam's baby. I think this year, he actually took it to the next level where as big as you can think you could go, and as much as you can, achieve or dream, you can believe you can achieve. So this is part of that same continuum. And I've just been fortunate to actually be linking up everybody with Bombay Orthopaedic Society. And each time feeling happy that there are so many experts who have focused knowledge to share. And the thoughts behind each of these webinars have been to basically share case-based knowledge pearls and see the wisdom that comes from some of these stalwarts so that our members can then easily navigate challenges. All of you may be wondering, what is a pediatric orthopedic surgeon doing in the middle of all this? But I have a very, very special interest in shoulder because I deal with a lot of OBPI. And I must congratulate Prasad for really showing very good enthusiasm. He was completely sorted from the beginning about the program. He made his own flyers, really helped out with all the promos also. So I'm sure the viewers are going to be lots, and they all will benefit from the nuances and the tips that you all would be able to share through this case-based learning. So without much ado, handing over to Prasad. Please begin. Prasad, you're muted. You're muted.
Thank you, ma'am. Thank you very much. I think so. We're already about 15 minutes since I started. I think so. Ravi, what if you start with the program now? Yeah, Ravi, you're
Go
there?
ahead. Yeah, go ahead.
Yeah. Okay, great. So what we'll do is, because we're already about 15 minutes, we have about 1 hour, 30, 40 minutes. So to understand, shoulder is really growing big in our part of the world. There's a lot of interest in shoulder instability and cuff repairs, and also, as Dr. Gautam mentioned, about the shoulder arthroplasty. Today's program is designed specifically for shoulder instability, where we are going to cover right from A to Z. We are going to start with the basic managing of shoulder cases with the soft tissue lesions. We also have topics on the DAS, which is very, very anticipated. We're waiting for this for a very long time. Then we have something to covering about the posterior instability, the cartilage, and then we go for the bony topics. Ravi, we together will start moderating the session. And I would like to invite Nikhil Iyer, who's a good friend of mine. And he is practicing for us about 15 years. And he practices in few hospitals in Mumbai called as the Zen Hospital and Cobiella Hospital and the Gleneagles Hospital. Nikhil is going to speak on the Bankart and remplissage for shoulder instability. Yeah, Nikhil, all yours.
Yeah. Thanks, Prasad. Can you see my screen?
Yeah, we are good to go.
Yeah. Very good evening to all. Firstly, I'd like to thank Bombay Orthopaedic Society and BOSTAA, especially Dr. Prasad, for inviting me for this talk. Originally, we thought that glenoid and humeral bone loss were viewed very separately, but now we know that they are very closely related and contribute to recurrent instability. My talk today is on bone loss in shoulder instability. The case which I'm discussing is of a 35-year-old female, right hand dominant, presented with history of dislocation of the right shoulder due to a fall around 2 months ago. She has a desk job, has a sedentary lifestyle. She's had 4 further episodes of dislocation in this span of 2 months. On examination, there was no hyperlaxity. Apprehension test was positive. All range of motion other than the ABER were full. Her MRI, in the axial view, we could see a Hill-Sachs lesion and a Bankard's lesion. In the sagittal view, again, there was a Hill-Sachs lesion which was visible, but on the arm face view of the glenoid, there was no significant bone loss that I could really appreciate. In the sagittal view, in the coronal view, again, the bone edema due to the Hill-Sachs was seen, and a small interstitial signal in the supraspinatus, no obvious tear. Okay, this is the check arthroscopy, a diagnostic scopy. Seen from the posterior portal, you could see a large Bankard lesion all the way to 6 o'clock.
Nikhil, we can take a kind of a pause in the middle now.
Yeah.
Okay, great. So we'll also understand the panelists over here, people are there. So we did an X-ray, we did an MRI.
X-ray, unfortunately, I don't have one.
Okay, we did an MRI which showed a Bankard lesion and a small Hill-Sachs lesion too, right?
Yeah, it was a reasonably large Hill-Sachs lesion.
Okay, great.
Yeah.
Okay, the question is to you also and all the panelists. How often we do? Basically, she had about 5 dislocations. That's right.
Yes.
5 dislocations. A 35 female, a sedentary worker. Are you happy with the bony findings on the MRI, or you also do some kind of investigation like a CT scan or something like that?
Ideally, yes. Theoretically, the CT scan is better, but in regular practice, I go by the MRI images only.
Right. Yeah, Dr. Clara, because Dr. Clara, Dr. Chris, what is your opinion on, like, do we do CT scan or we are happy with the X-rays and the MRI over here?
Well, in my opinion, sorry?
Yeah, Clara, please go on.
In my opinion, particularly in this case, I don't see a justification to perform a CT scan because you see in the MRI, if there's bone loss, it will be less than 10%.
Right.
If you do a CT scan and you find here some bone loss, it will be less than 10%. So it will not be significant.
True.
It would need to be a significant glenoid bone loss for me to think that maybe a CT scan would make clearer the distinction between deciding between a bony procedure and a soft tissue procedure.
Okay. Great. Yeah, Nikhil, you can go with your case.
Yeah. So this was the diagnostic check scope seen from the posterior portal. You see a large Bankard lesion going all the way till 6 p.m., 6 o'clock. There was a flap there of the labrum, but when I excised it, it was a small bony piece too. The cuff looked all right. As you went behind, you could see that's the bare area, and there it was a large Hill-Sachs lesion. It actually was an engaged Hill-Sachs. You could see there is just on a lateral traction with a traction arm pulley, it was already engaged. Now this is the same thing from the anterosuperior portal. You can see there's a little bone loss anteriorly. I don't think it's significant. When we measured it, it was around between 8 to 10% bone loss. Again, when we saw posteriorly, there was a large engaging Hill-Sachs. So next, I'm just covering a little theoretical part. These are the findings. There's a Bankard from 3 to 6, a flipped labral fragment, a small bony fragment in it, 8 to 10% glenoid bone loss, and an engaging off-track Hill-Sachs. Now, up to 90% of patients undergoing arthroscopic evaluation of recurrent shoulder instability demonstrate an osseous defect of the glenoid of the glenoid or the humeral head. Now, the various bone loss concepts that we speak about are the glenoid bone loss, humeral bone loss, a bipolar bone loss, where the concept of the glenoid tract, on-track, off-track lesion, and the distance to dislocation we'll cover here. One of the earliest descriptions of critical bone loss was by Itoy et al., where bone loss greater than 20 to 25% has been consistently defined as critical. Numerous studies after this also showed that 20 to 25% is considered a critical value of bone loss. In 2014, Saha et al. In a study showed that bone loss more than 17% was also significant. It showed poor outcome in only pure capsulolabral lesions. The same group, 1 year later, in 2015, had another study which said up to 13.5% was important. Anything more than 13.5% also puts the patient at risk. So that is considered, the 13.5 to 20 is considered as a subcritical bone loss. Now, a Hill-Sachs lesion is a cortical depression in the posterolateral head of the humerus. It results from the forceful impaction of the humeral head against the anteroinferior glenoid rim when the shoulder is dislocated anteriorly. Now, the evolution of the bipolar bone loss, earlier Burkhardt and De Beer described the inverted pear-shaped glenoid in glenoid bone loss, and they also spoke about the concept of an engaging Hill-Sachs. Yamamoto described the glenoid track, and Giacomo defined the on-track and off-track lesions. Lee and Barrow have recently highlighted the importance of distance to dislocation. Now, the glenoid track is the contact zone of the glenoid on the humeral head when the arm is moved along the posterior end range of motion. Now, to measure the glenoid track, either on a CT or MR, you find the diameter, maximum diameter of the glenoid, 83% of that minus the anterior bone loss. This is the glenoid track. And the Hill-Sachs index is measured. This is by the size of the Hill-Sachs plus the bony bridge between the lateral edge of the Hill-Sachs and the medial edge of the rotator cuff insertion. Whenever the Hill-Sachs index is greater than the glenoid track, it's called as an off-track lesion, else it's an on-track lesion. Now, of course, the first 7 points is how you measure the off-track and an on-track. The distance to dislocation is important when you are dealing with on-track lesions. To calculate the distance to dislocation, it is equal to the glenoid track minus the Hill-Sachs index. A distance to dislocation less than 0 is considered an off-track lesion. Now, it's like I said, it's important when we are dealing with on-track lesions, as all on-track lesions should not be viewed in the same manner. In 2021, Lee et al. Introduced this new concept of distance to dislocation. Their conclusion was a near track, one second. I lost my view, 1 second. Yeah, sorry. A near track lesion with a distance to dislocation of less than 8 mm, particularly individuals greater than 20 years, may be predictive of failure of an arthroscopic Bankart repair. So when you're using just a binary on-track or an off-track as a criteria for deciding your surgery, I think that is not adequate. That is what the study said. Just a moment, please.
So, Nikhil, we can see your screen, huh?
Yeah, can you see it now?
Yeah, we can see it.
Yeah, I kind of got lost here. Sorry. Okay. This study from Barrow et al. Also described, spoke about the distance to dislocation. The conclusion of this was on-track lesions. From on-track lesions, when the distance to dislocation is less than 10 mm, they are at high risk of failure, especially in athletes and high demand patients. Now, this is just, I'm going to skip this slide. This study spoke about the recurrence rate and return to sports with different surgeries. When a Bankart's lesion was done for an on-track lesion with less than 20% glenoid bone loss, the recurrence rate was found to be 10% and return to sport 85%. Least recurrence was found when a Latarjet was done for an on or an off-track lesion with more than 20% glenoid bone loss. The recurrence rate was only 2% and the return to sport was 90%. Now, this is just an algorithm how to approach a patient when there is the glenoid bone loss. If it's less than 13.5%, or between 13.5 to 20%, you need to see whether it's an off-track or an on-track lesion. If it's an off-track lesion, you go for doing a Letargy or a bistro or a remplissage with an arthroscopic Bankart or an open Bankart. If it's an on-track lesion and it's a contact athlete with a distance to dislocation less than 10 mm, then you can think of doing an open Bankart repair or Letargy or a bistro. Else, if it is more than 10 mm, it's best to do a arthroscopic Bankart. 20 to 40% a bony procedure is the best. Greater than 40%, either iliac crest bone graft or allograft is best. My next slide is the surgical slide. Is there anything we want to discuss before this? Prasad?
Yeah. So opinion of also Dr. Clara, Dr. Chris, is this, and Dr. Carlos also, do we follow the similar principles? Like, what's your critical point for the glenoid bone loss? Is it 20%, 17, 13.5? Athletes, non-athletes, do you do bipolar? Do you look for bipolar lesions? So some thoughts on those.
Prasad, if I may. The critical bone loss is a concept that is constantly changing.
Exactly.
It's variable, and some people will quote 8% as critical bone loss, and some will go as far as 20%. So it's a concept that is very fluid, and I think it's more the bipolar component than a pure glenoid bone loss that really is an issue. I mean, at the end of the day, you have to be a little bit pragmatic, and you can do all these calculations and get CT scans and do the on-track, off-track, and distance to dislocation calculations. But at the end of the day, if you are looking at the patient and you think that the bone loss is significant, and there is no good way of actually conveying that other than through experience, I suppose. But if you look at it and you think it's big enough, then I would do a bony procedure. If it feels reasonable, the Hill Sachs is not engaging on examination, then a remplissage would do. But I would be very wary of just doing a Bankart repair nowadays. I tend to actually, for type 1, for traumatic ones, I would have a very low threshold to add a remplissage to the Bankart repair.
Sure. Dr. Chris, what's your opinion on this?
Yeah, I think I'd very much echo with Carlos. I think it's a little bit one-dimensional just to be looking at bony anatomy. You've got to consider your patient as a whole. You've got to evaluate what their expectations are, particularly if we're thinking about sport. A lot of our sports men and women have got short lifespans in their careers, and if you just manage them based on bony anatomy at all, you're going to be failing them. So there's a lot of conversation to be had, particularly with these mid-range bony loss, about return to play, soft tissue versus bony procedures, as well as the recurrence rate. So I think taking what you've discussed already, I think in my hands, the MRI sequences are more than satisfactory to assess bone loss accurately for me to make a decision with the patient. I think if you've got a bad MRI scanner, then maybe a CT scan is indicated. And I wrote down a question to ask the rest of the panel. Carlos, you've already covered that. It said, what is the indication of a isolated Bankart repair in this day and age without the addition of a remplissage in the patients with a Hill Sachs lesion? I think the evidence is so strongly in support of a remplissage, and the downside of a remplissage is really, I don't know how to do it, or it takes me a long time. So the more you do it, the more successful it'll be for your patients, and the easier it is to do.
Okay, so Chris, if you have a patient, a 10% glenoid bone loss, has a significant Hill Sachs, is an athlete, will you add an remplissage or not add a remplissage?
They'll have a remplissage, but it depends what is their risk of further dislocation during their sport. If they're a high-risk dislocation collision athlete, they'll be having a bony procedure.
Okay, so you'll add a bony procedure for that. Okay. Do we have Nagraj over here?
Yeah, hi Prasad.
Nagraj is
Can you
there.
hear me?
Yeah. So Nagraj also is a very celebrated surgeon over here. He also is doing good volume. Nagraj, you would throw some light on this. So we have this patient, 10% glenoid bone loss, 8 to 10%, has got a quite significant Hill Sachs. He's got a medialized Hill Sachs lesion, not very deep, but a significant one. What would you think for this patient?
So I think the present consensus is that your results, there are multiple studies which show that if you do a Bankart with a Remplissage, the results are almost matching even to a bony procedure. Recent literature has come out that way. So, and even in cricketers, even in overhead athletes, if we do a Remplissage, we have not really seen significant restriction of external rotation as such. However, if it's an elite overhead bowler or if it's a javelin thrower, then itself I'll be bit of concern to do a Remplissage per se. And even if I land up doing it, then I make sure that they stretch themselves out very well at the very beginning itself. I put them on a proper rehab program. So to summarize, for a 10% bone loss with a medialized small Hill Sachs or a large Hill Sachs, I wouldn't hesitate to do a Remplissage with the recent literature supporting Bankart Remplissage equivalent results to a Latarjet.
For a 10% bone loss, approximately.
For a 10% bone loss, yes. But everything changes the minute it's a contact athlete. The minute it's a contact athlete, then we are dealing with a different patient population. In that case, for example, in our country, we've got Kabaddi, some rugby players. So these players are a different entity altogether. There, the ratio of bone loss, if it comes around 12%, if it comes in that range, I wouldn't hesitate to do a primary Latarjet for them. If it's a high-end contact.
Right. Okay, Nikhil, we'd like to hear what you do for the patient.
Yeah. So this is the video of the surgery. The Hill Sachs region, I have debrided it. I always like to debride it thoroughly so that it's good bony bleeding surface. Once debrided, I also use a rasp on the capsular side of the infraspinatus. I've used two all suture anchors, one at the lower end, one superior proximally. And I pass these sutures through the infraspinatus using a bird beak. The passes would look high because these are in the tendon. The most common mistake is if you come lower down, you end up doing a myodesis rather than a tenodesis. Once this was done, I liberated the labrum anteriorly, got a good floating labrum higher than the level of the glenoid before I could start repairing it. Once it was liberated, I always use my 5 o'clock anchor as a double loaded anchor. I've used all suture anchors, a double loaded one. Pass the sutures, one through the inferior labrum, one through the IGHL and the labrum. Then at the 4 and 3 o'clock, I've used a knotless anchor. I like using the knotless anchor because I'm able to pull the capsule up and tension it. Then I tied my inferior anchors. I tied my 4 o'clock anchor first and then tied my inferior anchors so that there is no loosening once I tighten this. Then I put the last anchor, superior most. I have not cut the second anchor. Once I put this knotless anchor, I'll do a sequential tightening of both the sutures. So this helps me if any loosening because of the proximal shift is there in the second anchor, even that is taken care when I use a knotless anchor. So that's my Bankart's repair. Now this is the Hill Sachs. Even before this is the Bankart seen from the posterior side. And from the anterosuperior portal, this is the Hill Sachs, which is the knots are not even tied yet, but it's already moved posteriorly because of centralization. The knots tying for the Hill Sachs, I do it blind.
That's a standard anterior Bankart repair using combination of knotless and knotted anchors and kind of a remplissage. Do you go in the subacromial space to see your knots, or it's
no?
blind?
I do it blind. What I do is I put my Baviskar rod till it indents on the infraspinatus tendon, and I put a cannula there.
Right.
So till the cannula indents, so I know that I'm past the deltoid and only on the cuff tissue. And then I pass the bird beak to pass my sutures, shuttle the sutures.
Right. It's always two anchors, or also sometimes one anchor is also used?
If it's a small Hill Sachs, I'll just get away doing one anchor.
One anchor. And your position of anchor is more medial, lateral, superior, inferior? Like
so
how?
earlier I used to put it right at the edge, but now I put it a few lateral to the edge.
Okay. Anyone of different opinion? What is the position of the ankle remplissage, if anyone is doing it?
Well, in my case, I always place it more laterally,
Okay.
exactly because I want to avoid losing external rotation when
Okay.
I use technique in overhead athletes that cannot afford to lose external rotation.
Right. But do you have a risk of engagement then if you're putting an anchor more, if you're not making the defect extra articular, are you at risk of having some engagement? Or it doesn't matter?
No, we test the repair afterwards and there's no engagement.
Perfect. Okay,
So
great.
Prasad, one thing what I do, Prasad, let me add, I internally rotate the humeral head to see where the edge touches on the infraspinatus. Because the most common mistake is to take the bites a little more medial. That is what makes you lose the external rotation.
Right.
So that my bites are only through the tendon, not the muscle.
That's right. Yeah. So you go more lateral, you go towards the tendon rather than coming more medial. That makes sense. Perfect. Thank you, Nikhil. Any questions for panelists for Dr. Nikhil? Anything what they're doing different? They want to know.
No, just one, just to add to that. My view on the remplissage is not that you are feeling the Hill-Sachs defect. What you're doing is just medializing the infraspinatus slightly so that you reduce the anterior translation of the humeral head. So I think if you just think of the Hill-Sachs lesion, you will end up with a lot of stiff patients because big Hill-Sachs lesions, big medialized Hill-Sachs lesions, if you feel them completely, that's when you end up with loss of external rotation.
Perfect. Yes. Okay. Great.
Can I just add in is Nikhil, that's a really nice demonstration of a Bankart repair, and I think what is difficult in evaluating the literature is probably the number of poorly done Bankart repair surgeries that are sort of contributing to the literature currently. I think it is classed as a simple arthroscopic procedure to do, but as you've demonstrated really nicely, it has to be very carefully thought out, ensuring that you have adequate capsular shift and mobilization of the labrum from bottom to top. And it doesn't matter what you do and measurement of bone loss, you're going to have a failure if you don't do it well. So that's a really nice case to demonstrate that.
Thanks for your kind words, Chris.
Thank you, Nikhil. Thank you, Nikhil. Great. So we had this first case by Nikhil, which was talking about Bankart and remplissage. I would hand over the presentation to Dr. Ravi, who is okay. I would hand over to Ravi. Ravi is a good friend. Chalo. Okay. Ravi is a friend for me for last about 40 years, and you can see my screen there. And you already shared it. Okay. So Ravi, are you there, Ravi?
Yeah. Okay.
Yes, he's there.
Great, Ravi. Okay. So for the next three speakers, I would hand over the podium to Ravi. He'll take it from now. If you know Ravi, I know Ravi for about last 40 years. We were together right from the school days, and we also studied together in KM, and we also did orthopedics together. Ravi has a lot of laurels to him. Now he's working as an honor lecturer here in Liverpool, and he also is an examiner for FRCS and MRCS. I think he holds the post of treasurer for the BOSTAA, a very prestigious post over there. He's been an orthopedic expert to the Paris Olympics there in 2024. And that's our last few days in Finland. We were together in Finland. We had about temperature as low as -35. That's our few moments together, Ravi. Ravi, all to you. You can take it from here now.
Thank you, Prasad. I'm going to take this opportunity on behalf of BOSTAA to just give you a bit of a briefing. And first of all, I would like to thank Bombay Orthopaedic Society on behalf of our president Fazal Ali and the rest of the BOSTAA members to giving this opportunity to collaborate and have this pearls of wisdom shared between two continents. So BOSTAA is a society of the orthopedic surgeon with special interest in the management of sports injuries and arthroscopic procedures. And our whole idea is to improve understanding about the management of sports personnel understanding the philosophy behind it, and give them the best possible chance to let them do what they want to do, to get back playing and perform. And it's not about just a surgery, but getting the rehab in place, getting the operative technique, evolving with the new technology available, and also the post-op protocols and the preventative measures to take. So BOSTAA has been growing over last couple of decades and having its presence in many national orthopedic meetings, and it's expanded its wing in the international societies as well, like Bombay Orthopedic Society. And as we all know that the sports medicine has evolved significantly over the last couple of decades, and especially after London 2012 Olympics, it has taken off at different level. Uh, and BOSTAA has been involved in organizing its annual meeting where the scientific discussion takes place. Papers are presented by trainees and allied healthcare professionals, consultants all across the countries. The next annual meeting is one of the most coveted sporting venues in Wimbledon. So we all welcome you all and hope to see you there. We also offer traveling fellowships for the suitable candidates, and we also provide some research grant to continue with scientific research. So that's about BOSTAA. So I'm going to take this opportunity to introduce our next speaker, Clara Azevedo. So Clara has joined us from Lisbon. I met her briefly last year in one of the courses. So Clara is a very recognized shoulder and elbow surgeon in European and worldwide community. She is the head of shoulder and elbow unit in Sam's Hospital in Lisbon, co-founder of shoulder.pt, which is providing a platform for scientific evidence, various techniques. And also she has her teaching hat involved in ESCA, ASACOS, you name it, SECEC, and part of the editorial board for America's Journal of Sports Medicine. So Clara is with us to present management of subcritical bone loss in glenoid along with the Hill-Sachs lesion and how her unique procedures is helping her patients to get better. Clara, over to you.
Thanks so much, Ravi. Thank you for inviting me for this the Bombay Orthopaedic Society BOSTAA webinar. It's an honor. I'm going to start sharing the screen so that I can show you my talk. Can you see it? Yes? Okay. So as Ravi said, I'm going to present a case where the choice of treatment for the subcritical anterior glenoid bone loss with a Hill-Sachs lesion was to perform a dynamic anterior stabilization with the augmentation with the Hill-Sachs remplissage. So in this case, I'm going to minimize myself so I can see my presentation. So this was a 39-year-old pharmaceutical man who was right-handed and a smoker. And he suffered several right shoulder dislocations. So he practiced paddle and ski, but at a recreational level, so he's not competitive. And his first dislocation happened when he was 16 years old after a motorcycle accident. Then he had 4 episodes, and he underwent arthroscopic Bankart in another institution, finally when he was 23 years old. However, he recurred 3 years after his arthroscopic Bankart repair at 26 years old. He had another 3 episodes. The first one was traumatic, so after a fall. Then it was playing paddle, and finally the last dislocation he had while he was sleeping. So this is how he came to me, and he had poor WOSI scores and a very low ROE score. Even though he had full range of motion, as you can see here, or at least almost full range of motion, he, as you can see, couldn't have quality of life while dislocating his shoulder during his sleep. And he wanted to continue to be this weekend warrior, playing paddle and skiing. So he needed a solution. And I don't have the X-ray here, even though, of course, he did an X-ray. But I do have his MRI, and you can see the image acquisitions in axillary incision incidence and the coronal plane and the sagittal view. And what I want to highlight is that we can see it has a SLAP2 type lesion, and it has a bipolar off-track lesion. So as Nikki so well presented previously and showed us that this nowadays is not only about off-track issue. As you can see in this guy, he had a near-track lesion because he has less than 10 millimeters of distance to dislocation. So he had a 20 millimeter Hill-Sachs interval with a 17 millimeter glenoid track. So he had on average of 14.9% of anterior glenoid bone loss using the best fit method to measure the defect, which is usually what I do typically in all my patients. So as we were discussing, I always use MRI, particularly because it's not the case. This guy is 39 years old, but many of my patients are teenagers, 15, 16, less than 20 years old, and I'm concerned about repetitive CT scans in these patients, preoperative, postoperatively, and MRI is innocuous. And I can distinguish between less than 20% to more than 20% of anterior glenoid bones, which is what is significant for my decision. So you can see here the SLAP2 lesion. And I'm checking the Bankart repair that failed. And now I'm going to see inferior lesion of the labrum as well. And then I test the engagement of the Hill-Sachs lesion, checking for any rotator cuff tear, of course, because he's 39 years old. You see the Hill-Sachs lesion here. And you see, of course, that it's engaging as the preoperative assessment showed us. And we're doing this in the beach chair position, so it's a bit different from what you saw just before, even though it was an amazing Bankart repair done in the lateral decubitus. We do this in the beach chair, and we use a posterior portal for the looking portal with a 4 millimeter 30-degree arthroscope, which is placed 2 centimeters medial to the posterolateral acromion, immediately under the acromion. And this is very important because, as you're going to see in this procedure, we need to see from posterior to anterior the full bicipital groove so that we can cut the transverse humeral ligament to dislocate the long head of the biceps to do the dynamic anterior stabilization. So this first portal is paramount to be immediately under the acromion, 2 centimeters medial to the posterolateral corner. Then we use a cannula, outflow cannula in the rotator interval, which we place from outside in. And then we do an anterolateral portal as well. But before that, we're going to do the Hill-Sachs remplissage. It's a bit different than what you saw in the previous presentation because we just use one all suture anchor, double loaded with sutures. And as I said, we place it lateral on the defect because we don't want to lose external rotation. And we do this, we place this spinal needle to decide the posterolateral, almost percutaneous portal to perform this Hill-Sachs remplissage, always looking from articular. And this is a small tip, is that you use piercing trocar so that you can do this percutaneously. So you go in through the infraspinatus and the capsule directly to the Hill-Sachs lesion, and then you remove the trocar, you have the guide there, and you can place the anchor. We don't debride because we're using a 1.8 all suture anchor, and we don't want to make the cortical bone frail, and we think that it's enough for the stem cells that come from the drilling of for the anchor to allow for the healing. And as Carlos Cobiella was saying, very rightfully so, the most important thing in this technique is not the fact that we're filling the defect, is that we're fixing the infraspinatus and the capsule here so that it works dynamically, pulling the humeral head posteriorly. So in this way, increasing the force necessary to redislocate. So then after this, we're going to implant the anchor. So you see here the pierced trocar. I'm going to fast forward because the most important part of this is not Hill-Sachs remplissage. So we go lateral, we place the all suture anchor double loaded with sutures, a 1.8 anchor. And then, like Nikhil showed, we also, this little trick is to slide the sutures to the anterior portal. You can just slide 3 sutures and leave one of them, which is already passed through the infraspinatus. In this case, we passed them the 4. So now we're going with the bird beak, also in a parachute configuration, through the infraspinatus and the capsule to fix it and to perform the iliac remplissage. And we're going to leave the sutures waiting for the end of the procedure. We don't tie the knots immediately because we don't want to push the head too posterior. Otherwise, we'll have no room for the arthroscope, because we're looking from posterior, and if we tie the knots from the iliac remplissage at this point, we'll have difficulty going with the arthroscope anteriorly to the bicipital groove to perform the DAS. So we leave the sutures and we'll tie them at the end of the procedure. So here we're just removing the sutures from the previous Bankart repair. Fast forward again. And then we're going, of course, to debride the anterior bone loss defect and try to mobilize the remaining labrum, because we like to repair the remaining labrum at the end of the dynamic anterior stabilization as well. So how do we do this? You see here the anterior glenoid defect. We're going to have to mark a placement for a 5 o'clock and the 4 o'clock anchor. We're going to use 2 all suture anchors, 1.8, double loaded with sutures. So we're going to end up having 8 suture limbs, and we're going to mark the 5 o'clock and the 4 o'clock anchor, and then we're going to drill first the 5 o'clock anchor. So this is what we're doing. We mark the 5 and the 4 o'clock anchor, and then we excise the middle glenohumeral ligament that you see here, very thick and traumatic from all these dislocations. Actually, this procedure was done, I think, less than 2 months after the last dislocation. And after we excise the MG gel, we place the split of the subscapularis tendon. So you see that we're coming from the anterolateral portal with the radiofrequency ablator, or we can do this from the anterior portal. And we do the split from intra-articular at the level of between the 4 and the 5 o'clock level anchors. So it will give you a split between the upper third and the lower 2/3 of the subscapularis tendon. And so after we do the split, you go through with the radiofrequency ablator, and you can go through with the cannula as well for suture management to be easier. So this is the 5 o'clock anchor. And what you were seeing, this was, I was checking that the suture limb slide, because this is going to be a double pulley technique. So we need to make sure that this suture slide. So first we pull on them together so that you arm the anchor against the cortical bone, because it's an all suture anchor, and then you pull on the sutures to check that they slide. They slide, and so the next step will be to retract the cannula again to anterior portal, this is the same video. And then we're going to pass these sutures from the 5 o'clock anchor. So just to say that we place the 5 o'clock anchor first, because we're going to do a labroplasty effect with the long head of the biceps on the anterior glenoid. So you place first the 5 o'clock anchor, and you place its sutures more distal on the long head of the biceps, so that you end up with this mini labroplasty effect, an L effect, going from 5 o'clock to 4 o'clock. So you have the 5 o'clock anchor, and you're going to use a spinal needle, a 16-gauge spinal needle, so that it fits this wire that has eyelets, and you're going to pierce through the anterolateral portal with this spinal needle through a most posterior and distal spot at the long head of the biceps, so immediately proximal to the transverse humeral ligament, and you're going to pass this wire, and you're going to retrieve it from the anterior cannula with this grasper to then place this suture, that usually I choose a blue one to be systematic, and we load this suture wire, this eyelet that's going through the anterior cannula with this blue suture, and then you pull on it from the anterolateral portal, and this way you're going to pass the first suture limb from the 5 o'clock anchor. And then you repeat this with a spinal needle. You grab from the anterior portal the wire, you load a white suture, and now you have a blue and a white, and you're going to tie these two suture limbs together. And this is going to be the first double pulley knot that's going to push the long head of the biceps at the end towards the anterior glenoid. So you tie, this is another tip, you can tie the knot outside. You don't need to do fancy arthroscopic knots. A surgeon's knot is sufficient. You tie the knot outside, then you cut these white and blue suture limbs. So you have at least less two suture limbs to confuse you inside the shoulder. And then you pull on the opposing limbs, and this will make this knot reach the superior border of the long head of the biceps, as you can see in the monitor there. So you're pulling on the blue and the white, and the knot that you tied outside is going to sit on top of the long head of the biceps. So now you have the first double pulley knot coming from the 5 o'clock anchor, it's tied. But you need to pass the remaining two suture limbs because this is a double suture, double loaded all suture anchor. So again, I pass the blue one more posterior and then the white one more anterior. And so you end up with 4 suture limbs passing through the biceps coming from the 5 o'clock anchor. And then you leave these suture limbs with a reference. I usually reference them with a Cocker clamp so that I know they're coming from the 5 o'clock anchor. And now we're going to place, again, through the split of the subscapularis tendon, the 4 o'clock anchor. So again, you check that they slide. You use the spinal needle to with a wire with eyelets to load it with a blue suture a little more proximally, because as I said, the idea is to have a labraplasty effect at the end. You load then the white a little bit more anterior, and now you tie these two sutures outside. You saw that I was careful to go in with a suture retriever to check that the two suture limbs are passing through the same soft tissues. Otherwise, this will destroy your surgery, because when you tie the knot, it will push everything in between and you will have trouble performing this procedure correctly. And then again, you have the second double pulley knot now tied coming from the 4 o'clock anchor, but you have to pass the other blue and the other white suture through the long head of biceps. So at this point, you have a 5 o'clock and a 4 o'clock anchor, and you have all the sutures passed arthroscopically through the long head of the biceps. Now you can shuttle all the sutures that were not tied to the anterior portal, because you don't want to cut these sutures, and you're going to have to cut the transverse humeral ligament, because what you need now that happens is that this long-headed biceps dislocates medially. So as I was saying, if you had tied Ilsex remplissage knots, this would be impossible, because what we're seeing now is we're looking from the posterior portal, and we push the arthroscope anteriorly, and this patient is in the beach chair position, so they have their shoulder in forward flexion, on average 70 degrees of forward flexion. And this is why you have this tunnel view looking from posterior, and you can see the bicipital groove, and you can, through the anterolateral portal, using the radiofrequency ablator, cut the transverse ligament, which usually is 14 millimeters long. And you'll know that you've cut it enough when the long head of the biceps dislocates medially, because it's being pulled by all the sutures that you pass. You have to be very careful here, because there's always an artery here on the transverse humeral ligament that starts bleeding. So you cut and you coagulate, you cut and you coagulate. This is the bicipital groove. And once you see it's trying to bleed there, you have to coagulate. Once it's completely cut, it will dislocate from the groove. And you're looking from posteriorly, and it's going to look very nice. You see it bled a lot. I edited the video so you didn't see the red C. So we coagulate, and the biceps has dislocated medially. So at this point, the next step is to tenotomize the biceps from the superior labrum. So you tenotomize using the radiofrequency ablator coming from the atrolateral portal. And once it's completely freed from the superior labrum, it will start to want to go through the subscapularis tendon split, because you have the sutures coming through the split of the subscapularis. You can use the suture retriever to lift the upper third of the subscapularis. And so at this point, what's happening? Outside, we're pulling first on the white and blue suture that were not tied from the first double pulley knots. So from the 5 o'clock anchor, from the 4 o'clock anchor, I'm sorry. So the second double pulley knot, you should pull on the 4 o'clock anchor knot first, so that it doesn't kink. And then once it starts going through the split, you start pulling on the opposing limbs of the 5 o'clock anchor. So this is what's happening. We're pulling on the opposing limbs of the 4 o'clock anchor, and then on the opposing limbs of the 5 o'clock anchor double pulley knot. So then you see 4 o'clock anchor, 5 o'clock anchor, and you see this mini labralplasty effect that's happening. We're testing internal and external rotation, and then we shuttle the suture limbs to the anterolateral portal. It's easier to tie the knots than to tie them through the split. And then you can, instead of cutting the sutures, you can use the suture limbs to pass them through the labrum. And you can, in this way, have a sort of a Bankart repair done on top of the long head of the biceps. So here we're checking that it doesn't dislocate, even though we haven't tied the Hill-Sachs remplissage knots yet. And then before we tie the Hill-Sachs remplissage, we check again that the patient has full external rotation. You see long head of the biceps in front, full external rotation. And then we place the shoulder in full external rotation when we tie the Hill-Sachs remplissage knots, so the 2 knots, which we are doing here. We're tying the knots, and then we check again that the patient has full external rotation and it doesn't dislocate anymore after the Hill-Sachs remplissage. So this is the patient at 1 month post-operative. And how do you get the patient to have almost full range of motion at 1 month post-operative? It's because we are very aggressive in the rehabilitation. So they start active assisted full range of motion immediately. We don't immobilize the patients. They wear a sling, but it's because we have to protect the biceps healing for 6 weeks. So they cannot bear weight on their biceps for 6 weeks, hence the sling, but they start a full range of motion of the shoulder immediately. Because as you saw, it's not a Bankart repair, and the fixation is very stiff. So you have 4 knots in 2 anchors fixing the long head of the biceps. So we are not concerned about losing the healing of the repair. We're concerned about overhealing on the split of the subscapularis, or even though we excise the MGHL, that it can have adhesions. So we want them to immediately externally rotate their shoulder to avoid this. This is at 5 months post-operatively with almost full range of motion. And you see here the biceps is a little different at this point because we didn't allow him for a lot of strengthening of the biceps. It was started only after 6 weeks. And this is typically we do an MRI all our patients at 6 months to check that the biceps is healed in the anterior glenoid and that we had no failures of the biceps healing, as is the case in this patient. And here's the same patient at 12 months post-operatively, already skiing and doing all his weekend warrior activities. So again, paramount for not losing external rotation is that they start immediately external rotating their shoulder completely as tolerated, but protect flexion against resistance for 6 weeks. And for this, it's best that they use a sling. Otherwise, they will forget and they will pick up a weight, and then you risk failure of the long head of biceps healing to the anterior glenoid. And then they start progressive strengthening of their biceps. And we only allow them to start contact sports after 6 months. So this is the major difference between this technique and the Latarjet. And sometimes patients opt for a Latarjet because they want to return to sport earlier than 6 months. And you cannot safely let them go back to sports before 6 months with a dynamic continuous stabilization, even though I have some crazy patients who went playing hockey after 4 months and they were well, but scientifically we cannot advise this. So our experience is relatively short. So we have done this procedure to date in 59 patients. So here is the data of 58 patients until 2025, of which 29 patients have more than 24 months of follow-up. And on average, our patients had 9% of anterior glenoid bone loss. And a curious fact is 62% of these patients had either a SLAP 1 or a SLAP 2 lesion. So this is one of the best indications for the dynamic anterior stabilizations, is when you have a SLAP and an anterior labrum lesion. So you're filling two needs with one deed by doing this anterior glenoid tenodesis of the lung at the biceps. You're treating SLAP and you're treating the anterior labrum lesion. A lot of our patients, so 67% of our patients had engaging Hill-Sachs lesion, even though on average, patients were on track. So our philosophy changed after a while of doing dynamic anterior stabilization. We started out doing dynamic anterior stabilization in isolation, and this is one such patient. So here he was at 1 year, and this is at 3 years. You see he has an immobilization on left shoulder because he had a motorcycle accident 3 years after his dynamic anterior stabilization on the right shoulder, and he dislocated the left shoulder. So his right shoulder survived the motorcycle accident. Clinical scores are significantly better after this procedure. We did have a recurrence rate of 3.4%, and the two patients that dislocated were this difficult population of severely hyperlax patients. So these two patients that dislocated had a Batten score of 8 out of 9. They had an MRI after they dislocated, and their biceps transposition was intact. So they dislocated their humeral head under the biceps. And what we learned from these two cases was that in severely hyperlax patients, the dynamic anterior stabilization, like a Latarjet, is not enough. So you need to do something else. You need to address the inferior capsule insufficiency as well. Otherwise, it will dislocate under the DAS, or they will dislocate over a Latarjet. So this is a very difficult population. So as I said, after 25 cases, we started adding the Hill-Sachs remplissage in all the patients that had Hill-Sachs lesions, regardless of being on or off track. And the rationale here is that if you're not feeling the defect, you're increasing the force necessary for this humeral head to translate anteriorly, because you're placing a posterior restraint, which is dynamic. So when the patient contracts the infraspinatus, they pull the humeral head posterior. So what this does is this protects your anterior repair, regardless of it being a Bankart or being a dynamic anterior stabilization. And we feel that this will allow our patients who practice collision sports to be safer and have less recurrences. But we'll need to show this scientifically. So we're following our patients, and we hope to show this in the near future when you have a minimum follow-up of 2 years in this historical comparison. So our series of patients, we have no biceps complaints, which is meaningful. And as you saw, even the two cases that dislocated, their biceps was still intact. So we have no deformities, no pulpi, no failures in the biceps. This is what you see in the literature regarding the clinical results that have been published. So you have the inlay dynamic anterior stabilization technique that was pioneered by Philippe Collin and Alexander Laderman. And they also had no long head of the biceps complications in their technique, which they used in patients with less than 20% of anterior glenoid bone loss. They had 3 recurrences, but early on their learning curve, where they moved their more inlay repair to a slightly more lateral repair. So they started placing their interference screw a little more lateral. And maybe this is why their technique is now more successful, even though Philippe is now doing onlay techniques. We published our first results after 15 patients had a minimum follow-up of 1 year, so at a mean follow-up of 2 years. And at that time, we had only 1 recurrence, but we have continued to follow our patients, and now we have the 2 cases, which are both hyperlex, but we have no biceps complications, again, as I said. And another dynamic anterior stabilization inlay technique published in China has shown, again, very good results at a minimum follow-up of 3 years with no recurrent dislocation, so just 1 subluxation and 1 positive apprehension, and again, no biceps complications. And from Brazil, another technique also without any recurrent dislocations or apprehensions or long-headed biceps complications. So I'm not an advocate that you should use the dynamic anterior stabilization if you have other options. I'm an advocate that you know this technique and you have this in your toolbox, because it can be very useful in patients who are very young, where you want to avoid the risks of having serious complications in this very young population if you don't have a high volume of instability cases, because you need a lot of experience to do a technically perfect Latarjet. And this is a relatively easier technique. It's not easy, it's somewhat complex, as you saw, but you can use the same instruments you use for Bankart repair. So if you find that your patient has more bone loss than you anticipated preoperatively and also has a Hill-Sachs lesion, you can safely use this technique, which it doesn't have a record of severe complications in the very young population, and the results are very promising in the literature. So I use it even in patients who practice contact and collision or overhead sports. And if the patient is competitive, I discuss the Latarjet if they want to return to sport earlier, because this technique has to have 6 months of no contact sports to be really successful. And so this is my go-to technique in patients with subcritical anterior glandular bone loss with or without Hill-Sachs lesion. So in summary, it's a dynamic technique where you have a hammock and a sling effect, because you're using the biceps through the subscapulary split. So it's pushing the subscapulary tendon down in the first degrees of abduction. And at 90 degrees of abduction, it works as a sling in front of the humeral head, stopping it from dislocating anteriorly. The advantage of doing it only, so you have the anchors on the articular cartilage, is that you have this labroplasty effect. If you use all suture anchors, you're mimicking the effect of a missing labrum in patients who have chronic dislocations and don't have any soft tissue anymore that you can repair there. And with this labroplasty effect, you can increase the concavity compression, and theoretically, this will be more advantageous than an inlay technique where you're medializing your dynamic anterior stabilization. Also, as you see from biomechanical studies that you can find in the literature, there is no loss of external rotation in the biomechanical studies that have been done, and most of the clinical studies show no loss of external rotation and no loss of a significant external rotation. Only the study by José Carlos Garcia showed an average loss of 5 degrees of external rotation, which is not significant. And in our series, there's no loss of external rotation. So very good technique, even for overhead athletes. It decreases the anterior glandular remote translation in patients with 10 to 20% of anterior glandular bone loss. This has been shown biomechanically. As I said, deals with the slap lesion. You fill 2 needs with 1 DIT. It's a tenodesis on the anterior cartilage, anterior glenoid, I'm sorry. Also, if you use this all suture anchor technique, you have no hardware. You have all suture anchors, and you don't risk any neurovascular complications, because as you saw in the videos, we're always lateral to the conjoined tendon. We're not placing traction on the conjoined tendon, so we're not risking a lesion of the musculocutaneous nerve like in a Latarjet. Also, we're far we're lateral from the axillary nerve, which you can see from in the split, and we don't touch it. We don't use retractors like in the open lateral that can damage the axillary nerve. So no neurovascular complications. Also, the fact that you're using all suture anchors make for easier revisions because it's low profile holes. You can drill over them if you need to do a revision. And also you have no CT scan artifacts if you're a fan of CT scan controls because you don't have any metal. You use only 3 arthroscopic portals and the same arthroscopic instrumentation you use for Bankart repair. So if you need to change technique and you have this in your toolbox, you go ahead and you do a DAS. You just add another portal for the Ill-Sachs remplissage, the posterolateral percutaneous portal. However, you do have to delay the return to play only at 6 months for contact sports if you want to be on the safe side with the technique. And my tips are that you use the perforating trocar as I showed you, place the anchor for the Ill-Sachs remplissage lateral on the Ill-Sachs lesion to avoid losing external rotation. Tie the knots at the end. Use this 16-gauge spinal needle. It's cheap. It's readily available in every OR. And this will do only puncture holes on the long head of the biceps. We have no tears of the long head of the biceps with this. It's very low profile perforation of the biceps with these 8 sutures. Cut the transverse humeral ligament with the shoulder in the beach chair position in forward flexion so you can have this tunnel view. It's down the bicipital groove and you can safely cut it. Protect your biceps from loading for 6 weeks. And this way, in our series of 59 patients, we had no biceps failures. And start external rotation 1 immediately and forward flexion immediately to avoid stiffness. You can trust this fixation. It won't fail. It will fail if you load it for the first 6 weeks. It won't fail with full range of motion. So it's safe for this type of patients and do the Ill-Sachs remplissage regardless of on or off track lesion, because then you increase the force necessary to dislocate. But beware of severely hyperlax patients because you risk having a redislocation under the biceps. So always add the plication of the inferior capsule to avoid failure of a DAS in a severely hyperlax patient. And you're invited to our course this year in Lisbon, Cadaver Lab. So if you want, scan the QR code and visit us in Lisbon to learn how to treat challenging rotator cuff tears. So not the DAS, I'm sorry. Thank you. Thank you for your attention, and I'm finished.
Yes.
Thank you, Clara. Such an insightful presentation, and I'm sure a lot of us will have some question. I'm just mindful about the time. Prasad, are we okay to take questions, or you want me to proceed with?
Because we're already going late. We are already about more than an hour. We have 4 talks to go, but quick 2 or 3 questions should be good because wonderful talk by Clara. We all want to learn something about DAS over here. Few take-home messages. So you have a very high posterior portal. That's very critical. So your viewing portal has to be very high. So your starting portal. So when you're cutting your THL, are you entering a subacromial space or it's intra-articular? When you're cutting the transverse humeral ligament.
No, we're always intra-articular. This surgery all inside the box. We never go outside the box in this procedure. You don't need to, because you're shuttling the biceps from the glenohumeral joint. This is one of the main differences of this technique from all the other dynamic anterior stabilizations.
True.
Also, we don't pull the biceps out. Philippe Collin and Oleg Milana and all the other techniques, they pull the biceps out to pass the sutures. We don't. It's all intra-articular.
Fantastic. That was a great demonstration. Any questions from the panelists?
So, can I ask a question?
Yeah, Nagraj, you go.
Yeah, hi Clara. So wonderful presentation. I watched your video on arthroscopy techniques many times and I've tried to recreate it. The question is again about onlay versus inlay. You told us that Dr. Ladaman has shifted to the onlay technique, but I always felt having some control on the biceps tendon, either you exteriorize it, whip stitch it, and then having some control in pushing it in would be better than the onlay because you're relying completely on the all suture anchor fixation, which sometimes we worry can just rip off based on the bone quality. So what do you do in such a situation where the bone quality is poor, and with your double pulley technique, you actually land up ripping off your anchor? Is that a concern in terms of biomechanical strength?
Yes, the situations I saw that happen were technical mistakes. So usually it's related to where you placed, either where you place the anchor. If it's not, you have to be medial to the glenoid bone loss. You cannot be on the area where you have no cortical bone, and then the all suture anchor will not be pulling on, will not have a buttress effect of the cortical bone. And also you need to always pull on the anchor to be sure that it arms. Otherwise, you risk when you're doing the double pulley, the shuttling, it can pull out. If you happen to have this accident and it does pull out after you implanted it, you can use a push-in anchor and load it with sutures and pass the sutures again. This is the advantage of doing these very low profile holes on the long-headed biceps, is that you don't damage the biceps even though you have lots of suture going in. So my advice would be to use a push-in anchor, and then what you can do is you can embrace the biceps with the sutures and tie the knot, because hopefully if the other anchor hasn't pulled out while you're sliding it. I see your point, but if you follow all these steps, this will be a very rare event that will happen to you. And I really believe that onlay gives you many more advantages than inlay, because inlay, it's too medial. If you do a tunnel, it's the long-headed biceps is too medial. You have all this range where the humeral head can translate and dislocate. So this is why, and this is particularly important in patients who don't have a labral anterior labrum anymore. So a patient who has no anterior labrum, if you do an inlay fixation, you cannot augment it with a Bankart repair because there's no more anterior labrum. So the risk of a failure will be much higher, as you can see from the early results by Alexander Laderman. This way, with onlay, with the labroplasty effect, you increase the concavity compression and you emulate this missing labrum. So it's more difficult for the humeral head to translate anteriorly. So I would insist on trying to be technically demanding in these steps of the implantation of the anchor, so that you don't happen to have this. But then you can use the push-in.
Great, Clara. Thank you very much. I think we'll move on to our next case. Before that, I would like to introduce Carlos Cobiella. Carlos is an established shoulder and elbow surgeon based at University College of London, and also a founding member and the head of the upper limb unit at Institute of Sports and Exercise Health at UCL as well. He's a well-known figure in the sporting world in terms of managing athletes with sporting injuries. He has got a significant presence in managing UK athletes at British Olympic Association, also part of the medical team at the London 2012, and I think it's such a joyful time, isn't it, Carlos, spending in Olympic scenarios. I had a first-hand experience with that, but he's well published and he has got his focus on teaching and education. So Carlos is going to touch base on how do we manage the posterior instability. Over to you, Carlos.
Thank you very much, Ravi, and thank you very much to the Bombay Orthopaedic Society for this kind invitation. Wonderful event. I'll start sharing my screen, and there we go. Can you all see it?
We can see, yes. We all good to go.
Wonderful. So I'm going to talk about posterior instability and my approach to it. My approach to instability in general is based on what I was taught at Stanmore and looking at the different types of instability, going from traumatic to atraumatic with predisposing factors to the muscle patterning issues. And in this case, I will present a case to illustrate what I see commonly, which is traumatic posterior instability. Posterior instability is not that common in terms of proportion related to anterior instability, but it's something that I think is much more common than we think, and we just miss it. This case is fairly barn-door, so I thought it would illustrate well what a traumatic case is. 20-year-old right-hand dominant man who was on a motorbike, was hit by a car and hit a curb. Sustained direct blow to the shoulder, and that was a year before he presented. And since then, he's had multiple episodes of subluxations. His shoulder dislocates, particularly when he puts his hand behind his back, and it will relocate spontaneously. It also subluxes when lying on it. So clearly there is an instability component. The question is it anterior, is it posterior? And on his examination, I found that he did have apprehension overhead in that he didn't like putting his arm up there, and resisted external rotation as well, which is unusual in anterior instability. I find O'Brien tests very helpful in these cases, and he did have deep pain when testing O'Brien, which is again quite revealing. His apprehension testing did not show instability. It was pain that he had, and on trying to relocate, that pain was exacerbated. And if you think about it, if the instability is posterior, just by pushing on the humeral head, you will get a little bit more pain, more posterior translation. So when I'm looking at diagnosis of instability, I'm looking at all these things. Are there any predisposing factors, the mechanism of injury, and the symptoms that are as opposed to anterior are pain and weakness. Anterior instability, provided you're not in a range of apprehension, you don't have any weakness and certainly no pain. So it's unusual to see these. And as I said, O'Brien testing, I find, will either cause pain generally. You need to be careful. If you do it violently, it might actually push the humeral head out of joint posteriorly, and that can be quite painful. And the pain can be either deep or posterior. So imaging, that is his imaging. And if we look at the axial, there's two things that we can see on, I don't know if you see the arrow, anteriorly, there is a reverse Hill-Sachs lesion, which is actually not big, but definitely there. And there is a posterior labral tear, almost in an ALPSA kind of pattern. So basically, we've got my approach, my surgical approach to these is very similar to anterior instability in terms of the deciding what type of procedure. If the Hill-Sachs lesion is quite large and may engage posteriorly, I might do an anterior remplissage as well as the posterior labral repair. As it happens in him, it was small. So basically, I took him to theatre, examined him. This is not him, this is another patient, but illustrating the kind of examination I do under anesthesia, anterior and posterior translation, see in which direction he's unstable, and in particular, load and shift testing. And his load and shift was positive at shoulder level posteriorly compared to the other side. It's quite important to look at the other side. We do have a control, which is great. When I treat these, I do it in a bid chair position, and I will use an arm positioner because I like to place the arm in external rotation to open up the posterior recess. That actually gives me access to the posterior recess and allows me to work there much easier. The posterior recess in a neutral position is quite closed as opposed to the anterior. And the portals I will use an anterior, a posterior, and a Wilmington portal. My working portal is the Wilmington portal through the infraspinators, and that gives me a straight access to the posterior glenoid. In this case, when I examined him, when I looked at him, diagnostic arthroscopy, his posterior inferior labrum was torn and unstable. And if you just look at the area here, the posterior recess was quite open. So standard technique, same as demonstrated beautifully before. The release of the whole of the posterior inferior labrum, going quite deep, making sure that you go beyond you get to muscle basically. So you've released the whole of the capsule, and then using a rasp prepare the posterior glenoid. I tend to use knotless anchors and place them. I tend to place one low, and that's the one that we'll use to do a superior shift. And then I will place another one a little bit higher, and on that one I tend to do a horizontal shift to close the posterior recess, which is with the arm in external rotation, closing them quite a lot. But I find that over time they will recover, that they will not lose internal rotation, and it actually, if I don't do that, they tend to be a little bit loose. I then place them in, I'm a little bit more conservative than Clara, but particularly with the posterior ones. And I place them in an abduction brace, external rotation to neutral for 4 weeks. And that actually, again, makes them quite stiff and motivates them to get going with the rehabilitation at 4 weeks. So that's my standard approach to a traumatic posterior instability. I'd also like to present another case, which is of the type 2s, the atraumatic. These are the ones that are not necessarily big trauma, but this man presented 5 years after having had a posterior labral repair. He never felt that he had good result after his initial operation, and was getting progressive stiffness and pain. And if I show you sequential MRIs, this one is from 2021, 2 years after the index procedure, and you can see the posterior labrum is healed but thickened. The striking thing here is the fact that he does have posterior glenoid dysplasia. He's got this posterior glenoid this posterior sloping, and the humeral head is slightly subluxed posteriorly, despite having had a good repair. So 2 years later, 2023, he's already having early osteoarthritic changes. His pain and his stiffness continued, and he had a capsular release, debridement, and assessment of the joint. At the time, that's what his glenoid looked like. Continued monitoring showed that he developed a big cyst, and after discussion with colleagues, we felt that cyst, he was at risk of fracture of the glenoid surface. So he had another diagnostic arthroscopy, and you can see here that the glenoid was already quite damaged, the chondral surface at the back, and he had an open posterior bone grafting of the cyst. So basically, this is a case where you start with glenoid dysplasia, and a posterior labral repair. I mean, glenoid dysplasia predisposes you to posterior instability, to damage to the posterior labrum, and doing a posterior labral repair is probably not enough. And at the moment, the current thinking and the way we are looking at this is that maybe these cases we should be more aggressive initially and do a glenoid osteotomy to realign the glenoid surface, an posterior opening osteotomy, very much like you would do a tibial osteotomy in osteoarthritis of the knee. And the initial results that we are getting in the group are quite encouraging. So it's something, a space to be watched and see. Because if we leave it, then we get this situation, 52-year-old man who didn't have a problem with his shoulder. Maybe he had some stiffness generalized since young age, but nothing terrible. He has a fall and he presents with this situation. And you can see again, posterior glenoid dysplasia, advanced osteoarthritis, and the only thing you can do, I mean, you can see that already there's chondral, full thickness chondral loss in the glenoid. And the only thing you can do for him is release him and manage him, maybe hyaluronic acid injections until you get to a replacement. So these are a particular group of posterior instability with dysplasia that I think we need to be very mindful of and maybe think outside the box when treating them, just not only addressing the labrum. Thank you very much. And like Clara, I would like to invite you to the London shoulder meeting, which you will be featuring prominently and discussing cases in May in London if you happen to be there. Thank you very much.
Thank you. Thank you very much, Carlos. And as we all focus on anti-instability, sometimes there are various concepts about managing posterior instability gets overlooked. And I think we need to be vigilant and we need to be mindful about what exactly we're going to do to prevent the recurrences. Anybody got any questions for Carlos at the moment?
Okay, so Carlos, great presentation, and we do understand that your posterior will have more of pain, and they will have a complete different spectrum of clinical symptoms. Just to understand, if you have a reverse Hill-Sachs lesion, and you have a deep reverse Hill-Sachs lesion on the anterior part, how we do the infraspinatus tenodesis? Is a similar procedure done for the anterior, for the reverse Hill-Sachs?
Well, in actual fact, if I'm thinking of doing a remplissage anteriorly, it's a much easier procedure in the sense that you would do a subscapularis repair on the defect without detaching the tendon. So it's exactly the same technique as the infraspinatus, but just going through the subscap.
Right, perfect. It's a similar way what we do the regular remplissage.
Yes, it's exactly the same, except that it's at the front and through subscapularis. So it's you just shorten the subscapularis slightly. It's the McLaughlin technique, basically. It's the old the old technique was to osteotomize the lesser tuberosity and move it medially, but we can now do it through the tendon without detaching it.
Right. You mentioned you're going to use knotless anchors. Any specific, are knotted anchors okay, or knotless is the go-to anchors for the posterior labral repair?
In general, for instability, I will use knotless anchors. That's personal preference. I don't like tying knots, and the technique for me is easier in that I pass a suture first, and then once I find the tension, I can decide where the anchor goes. Putting the anchor in and then passing the suture through the labrum doesn't always give me the tension that I want.
Makes sense. Okay. Any questions?
Right, okay. So,
Carlos, can I ask? Oh,
yeah,
I was going to ask Carlos a question about, because I think this, like you say, this is a really interesting area, particularly in relation to glenoid retroversion. So I think the demographic data seems to suggest that there's almost as many posterior retroverted glenoids in type 1 and type 2 instability posteriorly. But do you think that there's the same recurrence rate? Would you consider an osteotomy in a type 1 instability with a certain degree of retroversion, or is it mainly your type 2s that you're worried about?
Well, you see the type 2s are trickier in that there hasn't been a traumatic component. So it's purely the glenoid dysplasia that's displacing them. Just replacing the labrum where it was doesn't address the problem, and you're likely to get a recurrence anyway. So those are the ones that I would be more mindful. a traumatic one with a slight posterior sloping, you can get away with a labral repair and some tightening. But it's important postoperatively to see if the head continues to be posteriorly subluxed, because those are the ones that you need to monitor and maybe address. At the moment, we don't have definitive data suggesting that glenoid osteotomy is the solution, but I think, I mean, from the sort of common sense point of view, I think that's the way it's going to go.
Great. Thanks, Carlos. Very thoughtful message here. So I'm going to bring a dear friend of mine, Professor Chris Pitch. Professor Chris Pitch, I think we go a long way back. We were co-registrar together, Chris, at some point. So give me pleasure to introduce the Chris here, the consultant orthopedic surgeon at Manchester University Hospital, and also professor at University of Manchester. He's got expertise in complex reconstructive shoulder and elbow surgeries, and he's got special interest in biologics as well as 3D printing. Uh, he's got extensive research, and he's been well published. Got very much interest in the teaching and education, and he's also a director at Ortho Team Center in Manchester, which has got a special interest in delivering world-class diagnostic treatment pathways and research. So Chris is going to talk to us about the cartilage damage in the patient with the shoulder instability and how he manages that. Chris, over to you.
Great, thanks, Ravi. Great, and thanks for the invitation. This is really kind. I've just recently come back from Bangalore just before Christmas, which we've been setting up a really exciting new bioprinting relationship between India and the UK with support from the governments. So it's exciting times for our Indian-English collaboration ongoing. So this is an area, I think this is basically almost unspoken about in shoulder instability. Yet, if you look in the literature, more than 60 or 70% of our patients have cartilage defects, and certainly when I was training, ignoring them was the method of treatment. So let's have a look at this case. And for me, in the UK, a very typical case. 24-year-old rugby player. He's got shoulder instability without any obvious frank dislocations, but the third instance of leaving the field of play during a game, ongoing micro instability, and failing his return to play program. And so through my many times visiting India, there seems to be an increasing incidence of rugby playing in India, some great teams around Mumbai. And I think wrestling is probably your alternative to rugby. So when we look at his this player's MRI, we see quite significant anterior labral injury, but with a suggestion of quite significant cartilage defect. Now, I appreciate that all of the stuff we've been talking about today is about interpreting imaging, interpreting MRI scans, but actually our gold standard really is, and I say this to my patients, is I'm going to look inside your shoulder with my 4D, so 4K high definition camera, and that's really going to be our diagnostics finished. And I completely echo Clara's advice, is that development of multiple techniques that when you're in your surgery with the tools that you have available is really important when you're doing shoulder instability surgery. So I'm going to show you the diagnostic scope on this patient before we have see what the panel would do. And I think this is a fairly common occurrence for a lot of our patients. So you see in a lot of these micro unstable rugby players, they haven't got a significant Hill-Sachs injury. You can see something's going on with the posterior labrum. Posterior labrum often not showing up on some of our imaging, so really important to have a high index of suspicion. Always look at the posterior labrum. I've sort of worked out what I'm going to do with this patient, but I'm showing you at the end of the diagnostic scope. So what we're dealing with is a patient with quite a significant anterior chronic labral injury, posterior labral tear, and a significant cartilage defect. So I'm interested to know from the panel what they would do. Obviously, option E is anything else. So what I've seen mostly in the UK is medialize the labral repair, cover over the defect, just do a labral repair, leave the bone exposed, microfracture, some type of cartilage repair procedure, or actually this is a rugby player, I'm just going to do a bony procedure and forget about the cartilage defect.
Well, if I can go first.
Go for it, Clara.
Well, my concern here with the option A, or for that matter B, would be first that if you medialize this labral repair, the defect is fairly big, so you're probably placing your labral repair very posterior, and this will posterior inferiorly subluxate the humeral head, and this patient will lose a lot of external rotation. So for me, that would not be an option. Of course, if the patient is highly competitive in rugby player and wants to return to play fast, of course, the bony procedure would be the best option for him. Otherwise, you can consider the DAS and microfracture the exposed cartilage defect as well.
Yeah, what I'm really interested about return to play, particularly in rugby, because this is our main collision athlete. Actually, if we look at return to play, our soft tissue stabilization return to play is a mean of almost 2 months quicker than Latarjet. Even though there's no discussion with the club that they can't return before then. So I'm not sure, certainly in my experience, that Latarjet actually gives a player a quicker return to play. So I personally think that your DAS procedure is probably about level with the average return to play from the Latarjet procedure in the literature.
If I may, I would disagree on the return to play thing, because you can do a Latarjet and monitor bone healing with CT scans, and if at 10 weeks, 12 weeks, you can do a CT scan, and if there is bony union, you can get them back to play, which is something that we've done for many years and with good results. My concern would be the exposed bone and what to do with it. And in a collision type athlete, doing any kind of cartilage repair procedure probably would be futile, because they would destroy it, the first time they go for a tackle. Sadly, I would just, my view would be I'd do a Latarjet and monitor the progression of his cartilage degeneration.
So, Chris, you have interest in 3D printing, and so what is there? Do you see there would be a role of similar sort of lesion or bigger lesions to have a partial glenoid sticking on that lesion, and then do whatever soft tissues you got to do?
Well,
Or is it
certainly
too early to think about it?
certainly the end goal of a lot of the bioprinting groups is to have in situ bioprinting of cartilage. Obviously, it's in evolution. We've got a long way to go from that point of view, but a lot of these things you will probably miss on your scan, so you need to develop a range of techniques that you can react to this intraoperatively. And that's why a lot of the autologous chondrocyte implantation procedures aren't so acceptable in many countries, because it's so challenging. You have got to do an operation sometimes if you're not expecting a second and then a third to implant. So I think the future will probably come with in situ bioprinting. I think for me, a couple of things. I think if you look at the overall literature on return to play from Latarjet, it's actually a lot longer than a lot of people think. And I absolutely agree with Clara in terms of medializing this defect is in an already probably degenerate or a joint that's developing degenerative changes is probably not going to be acceptable. Just what I would say, a few thoughts just to make sure we progress on for this case. I think we need high index suspicion for cartilage defects in the shoulder. And this is really about any joint. Prevent macroscopic and also micro instability in the shoulder and promote the cartilage healing. This is a nice study showing that cartilage lesions found in 64% of shoulder instability patients, mainly on the glenoid, but with combined surface defects in a lot of them. But the problem is, if you just ignore them, you get significant reduction in functional outcome and also increase recurrence. And obviously in the shoulder, like a lot of our techniques, we're learning from other joints. So non-eruptive management, like we say, just covering up the defect. This is a typical case. Just put the labrum on the top. I think that probably is acceptable for very small defects. Micro and nanofracture, which we know, I think nanofracture is becoming much more acceptable, and the need to reduce the risk of subchondral bony collapse and increase risk of arthritis and the need for arthroplasty in the future. AC MACI, like I say, are difficult and challenging in a lot of markets, and I think that you're exposing your patient to multiple procedures, particularly if you're not expecting it. So this is something we've been doing for a number of years, and I suspect this is not going to be the final solution, but this provides an off-the-shelf solution for an acellular synthetic scaffold of hyaluronic acid. So except like a normal scaffold, it allows host ingrowth of mesenchymal stem cells. And what seems to be happening, particularly in what we've learned from the knee, is differentiating into more hyaline-like cartilage rather than fiber cartilage that you expect from a microfracture. So a lot more durable, particularly in these competitive athletes. So this is what we do, and effectively doing a similar kind of stabilization. In this case, micro instability symptoms, so no significant need for a large capsular shift. Very careful positioning of your labrum to ensure that you are not over tensioning and medializing, particularly in that joint that's starting to become degenerate, because for a lot of patients, probably not your rugby players, but a lot of throwing athletes, you're going to interfere with their ability to carry out. I'm a bit of a knotted anchor fan, but I see the benefits from knotless anchors. So prepare the labrum. You can see just onto the edge. This patient had a posterior labral tear, so very much as Carlos has demonstrated, posterior labral repair. Then you're left with your cartilage defect. We've done some nanofracture. You can see some bleeding of the bone, but we've not done full perforation. And then you can cut your scaffold into size and place into the defect, and then seal it into place with Tissil glue. Has been a recent systematic review in the knee looking at whether sealing with BMAC is more beneficial than nanofracture alone, and there doesn't seem to be. It's difficult to get imaging of these patients to really truly show infilling of the cartilage defect, but we thought this showed, and we've seen it in a lot of patients, pretty good recreation of that cartilage. So this is our pretty early series in rugby players, 16 male, 4 female. So with this, our return to play is 4.2 months, which is fairly average. We see return to play actually, interestingly, much sooner in the female rugby players, and we're about to publish a systematic review. And the sad thing is there's very little out there in specific gender differences in rugby, and all showing MRI features of hyaline-like cartilage remodeling. So I think this is probably an evolving area in cartilage defects and instability, and whatever your procedure of choice, you need to make sure that that is available to you in these players. Thank you. I'll stop sharing.
Okay. Thank you, Chris. There was cartilage has always remained a challenge. It's let it be knee joint or a hip or a shoulder has always remained a challenge. And the point well taken, if you have a smaller defect, linear defect, you can always use a microfracture. Larger defects will require roots. So these hyaloplast, what are these patches? These are kind of patches over there?
Yeah, so it's a hyaluronic acid fleece. So it works as an inductive scaffold. So it allows your stem cells that you're doing in a microfracture or nanofracture, you're expecting mesenchymal stem cell differentiation into fibrocartilage, but in a fairly loose area. You're hoping they'll sit within your cartilage defect and stay there. So if you've got your scaffold, then it gives it much more organized. It's a non-woven scaffold, but there's quite good alignment of the fibers, which is essential for differentiation of the cells. So it's really providing them with that structure to differentiate within.
And you expect to have hyaline-like cells over there.
Yeah, and certainly a lot of the retrieval specimens from the knee studies are showing much more hyaline-like cartilage rather than the fibrocartilage.
Can I ask a question to Chris? Great talk, Chris. Really good. I didn't get it. How long do you immobilize, if you do immobilize your patients? And did you see any loss of range of motion?
Yeah, no, good question. So we've not seen any significant change in range of motion from doing this technique to just microfracture alone. Obviously, these patients do tend to be a little bit stiffer than our standard even Hill-Sachs remplissage and Bankart repair and isolation with no cartilage defects. They have the same range of motion program, early range of motion. But for their isometric, they start a little bit later at about 4 weeks. So we're just a little bit more cautious about getting the cuff firing up against the defect, but we still want to get range of motion early.
Thanks.
Excellent.
Great. Thank you, Chris. Ravi, I'll take it from here now.
Sure. Thanks.
Okay, Ravi. So we call the next speaker, Dr. Nagraj Shetty. He's a dear friend of mine. He's practicing arthroscopy for more than about 15 to 20 years. He's been trained in Korea and in France and also the US. He works with me in a few hospitals in Mumbai. He works at Reliance, Lilavati, and Hinduja Hospital. Here back in Mumbai, he runs his own fellowship program, which is ISACOS approved program over here. He has about 4 students per year. So he's running an ISACOS approved fellowship over here. He has multiple papers and he has a lot of presentations right at the national and international level over here. And I would like to call Nagraj to talk on his significant glenoid bone loss, free bone block versus lethargic. Yeah, all to Nagraj.
Thank you. Thank you, Prasad, and thanks to Bombay Orthopaedic Society for this opportunity. I'll share my screen. So, Prasad, let me know if you can see my screen. Can you see my screen, Prasad?
Yes, we can see now. You're all good to go.
Yeah. So, I've been asked to speak about lethargic versus bone block. What is my thought process in 2025? Whether we have a consensus, we will get to know at the end of this talk. So, any bone loss talk, I think we need to mention this particular article by these legends who mentioned that a routine Bankart repair in a large series had good outcomes with just about 11% recurrence overall. However, the minute there was bone loss, either on the glenoid side in the form of an inverted pair glenoid, the recurrence increased to 67%. And as the bone loss increased, became bipolar, almost 9 out of 10 patients failed. I think this is the article which brought the attention of the world to the bone loss. Presently, I look at bone loss either as an acute fracture, in which case as a bony bankard, we do a repair. Attritional bone loss, this is what we see more commonly in 78% patients, and that is what we're going to talk about mainly. And rarely we see a significant attrition in about 11% patients, what we traditionally look at 30% plus bone loss or a banana glenoid. Let's talk about these two attritional bone losses now. Typically, you have a significant load and shift test. They have what is called as a mid-range instability, like you can see, easily dislocatable shoulders. What is the importance of this bone loss? Well, as low as 5 to 6 millimeter of bone loss anteriorly can lead to almost 20 to 25% glenoid bone loss. So that much amount of loss of bone, hardly 5 millimeters, can lead to a significant amount of bone loss, and that is something to be kept in mind. And 9 out of 10 patients of shoulder instability will always have some amount of alteration of their anterior glenoid rim and bone loss. This is a algorithm which we followed for many years, that roughly if there's about 25% bone loss and on-track Hill-Sachs lesion, you would do a Latarjet procedure. Is it still being followed? Well, the answer is no. There has been a lot of changes over the years. So let's discuss about a classic case scenario. In our country, the contact sport we have is Kabaddi, and this particular patient had about 20% bone loss. That's the Latarjet, classic indication for Latarjet. We do a CT scan at about 6 months to see the bony union and get them back to full return to the contact sports that they like to do. That's a classic indication. However, with the knowledge coming from E.J. Itoy, who reduced the critical bone loss from 25% to around 19%, and then John Tokish mentioned about the critical bone loss, reducing it further down and calling 13.5% as the new subcritical bone loss, but called it critical for an active military population. So the number of critical bone loss kept on coming down, and we came to the understanding of something called a subcritical bone loss also. With this understanding, in a contact athlete, we go ahead and do a bony stabilization even in the subcritical bone loss range. On an on-fast view, the minute I see a straightened border, I am concerned that typically this bone loss would be in the range of 15%. So I don't like to see a straightened anterior border if I'm planning a soft tissue surgery, and therefore I would be concerned and plan to do a bony surgery in these cases. So what to do when there is subcritical bone loss in the range of 13.5% to 20%? Around 20%, we know we're going to do a Latarjet, but what do you do when it is in that subcritical range? Also, the questions to be answered as, what about the Hill-Sachs? Whether the size of the defect, the location of the defect, the depth of the defect, and what about the bankard tissue quality? These are all the questions to be answered. The recent article in JSCS in 2024 showed that if you do a bankard repair with a remplissage, the differences are very less even if you compare it to an open Latarjet. So a bankard repair with remplissage well done can match your outcomes of an open Latarjet. So for subcritical bone loss, probably the first thing that you would do, if it's a good tissue quality, you would do a bankard with a remplissage and have some confidence that you get good outcomes. But what about the bankard tissue quality being bad? So let's discuss about a second case scenario. Here is a 21-year-old male who is a known case of epilepsy. He's been having instability episodes since last 3 years. He's been having sleep dislocations. And we made sure he's had a seizure-free period of 9 months. That's his MRI images. You can see he's got a small bony bankard. The bone loss is about 15%, but he's got a very, very large Hill-Sachs lesion. Now, considering an epileptic, considering the large Hill-Sachs defect, what are the treatment options we have? This is his video. Bankard repair or bony surgery. Among the bony surgeries, whether we do a Latarjet or ICBG, and what do we do about the Hill-Sachs? So these are the questions to be answered. I will go ahead with my presentation, and then we can take a discussion at the end. So, and what should be the sequence of steps? So I decided to do a Latarjet for him. What is the clinical relevance? Before we decide what to do about the Hill-Sachs, a very nice article by Emilio Calvo, and he talks about the clinical relevance of a persistent off-track Hill-Sachs lesion even after doing a Latarjet procedure. Traditionally, we do a Latarjet and we consider that the Hill-Sachs is not going to be an issue, and off-track Hill-Sachs will become an on-track Hill-Sachs. But he found in his study that about 12% of his patients of off-track remained off-track even after the Latarjet procedure. And he gave this hint that if your Hill-Sachs interval and you subtract it from a glenoid track, if the difference is more than 7.5 mm, the chances of your Hill-Sachs remaining off track is high, and the chance of failure will be there. And he noted about 3 subluxations in a series. So look for this number. If your HSI is a minus GT number is more than 7.5 millimeter, you need to do something for the Hill sacks. So the take-home message is always measure the glenoid tract, measure the Hill sacks interval in every patient, and beware of the Hill sacks which are large, but not just the large lesions, but also the ones which are medial and what are called as near tract lesions, and have a very low threshold to do a remplissage. Even if you are doing a Latarjet, don't just rely on your bone grafts, and do a remplissage whenever your HSI minus GT is more than 7.5 mm. These are the important take-home messages. So that's what I did. I put the scope in the anterolateral portal. I placed the anchor, as Clara also showed, in the Hill sac, but we didn't tie it. We passed the sutures through the infraspinatus. We went ahead, did the open Latarjet. I always do a capsular shift also, and then come back and tie your Hill sac anchors. So that's his post-op X-ray. As expected, they get good range of motion, but there was a twist in the story. He did well for 8 months. As some of these patients always do, he stopped his anti-epileptic meds. He had a full grand mal seizure and for a prolonged duration. And he sent me these X-rays. So the screws are broken. I felt that he has dislocated his shoulder again and failed the surgery. We got his reports done. We got his MRI done. But fortunately, the remplissage had healed well and the bone graft had incorporated in the 6-month period. So really, even after having a grand mal seizure, because the bone graft had healed and the screws broke, still he went on to do well. He didn't really have any major instability episodes. So what is the summary so far? Anywhere around 20% of bone loss, we do a Latarjet. In the subcritical range, we can do a Bankart plus remplissage, provided the tissue quality is good, literature supports that, and you would add a Hill sacks remplissage to your Latarjet to convert an off-track lesion into an on-track lesion, especially for the large lesions, where the difference is between the HSI and GT is more than 7.5 mm, and for the lesions which are extremely medial, the near tract lesions. But still the unanswered question is, what do you do when the tissue quality is poor, and if there is subcritical bone loss and there is bipolar bone loss? Is iliac crest bone graft or bone block procedure the answer for this? And what are the overall outcomes when you compare Latarjet with ICVG? What about osteolysis? What about persistently off-track Hill sacks lesion, which we just discussed? And is this persistence of Hill sacks lesion being off-track clinically relevant? These are the various questions. This is a very nice article by Philip Morador, which got the Neer Award in 2019. He compared the Latarjet procedure to the iliac crest. The outcomes were equal. Osteolysis in the ICVG group was significant. However, the remodeling was to the native glenoid dimension at the end of 1 year. Osteolysis in the Latarjet group, as the Giacomo has shown, almost 60% of the graft resorbed at 17.5 months. But like many authors also pointed out that irrespective of the osteolysis, there were good outcomes and only 2 failures were seen. So osteolysis hasn't been as significant of an issue. Laura Lafos in his article also has pointed out that if you do a Latarjet, most of the times your Hill sacks region will get converted on track. In 32% cases, it remained off track, but still there were no failures. And according to him, it is probably because of there is a significant enlargement because of the loading of the graft at the 3 o'clock position. So there is some enlargement which compensates for this osteolysis. And the conjoint tendon presence with the Latarjet adds some vascularity to your graft compared to the bone block procedure, which otherwise doesn't really have any vascularity. In the Philip Morador study also, they found that about 28% of their ICVG patients, the Hill sac remained off track, and in 20% of the Latarjet patients, the Hill sacs remained off track. However, still, in spite of the Hill sacs remaining off track, majority didn't really have any major dislocation. There were only 2 failures in spite of lesion being off track, and they were in the form of subluxations. So what's our take-home message? Our take-home message is that you need to be having awareness that you need to add a remplissage even if you're doing a bone block procedure, especially if your HSI GT difference is more than 7.5, especially if you've got a small coracoid. If you've got a good size coracoid, but the Hill sacks is very small and medial or very large, then you would add a remplissage. And the last case that I'd like to present is a 42-year-old male. He's had anterior instability, post open surgery 15 years back. He's always been apprehensive. even after the first surgery, multiple subluxations, sleep dislocations. Cuff is normal. So that's the large scar he has in the front of the shoulder. He's got 15% glenoid bone loss. He's got a small Hill Sachs there. Again, what are the options for a situation like this? Do you do a revision Bankart? There's a large scar there. Do you do open Latarjet? Do you do an arthroscopic Latarjet? Do you do an arthroscopic bone grafting with Bankart plus rempisage? Well, I decided to go ahead with the bone block procedure, and I'll tell you what are the reasons I did that. So that's his examination. That's the poor tissue quality that is there. So it's not amenable to any sort of a soft tissue repair. These are the ideal cases according to me. A subcritical bone loss, poor tissue quality, failed surgery, failed soft tissue surgery. So what are the steps? You take a traction stitch, you take a trans-subscap portal, take a traction stitch through it, use it like a retractor to open up that anterior space. You need to then burr the anterior glenoid to make it flat. Once you're happy with that, you measure the tentative size of the bone block that you want. Typically, we take about 2 by 1 by 1 centimeter. You can take from the iliac crest, you can take from the scapular spine, and now you can also take it from the lateral clavicle. But I really rely on the iliac crest more often than not. There are dedicated jig available from a couple of companies, which allows you to drill 2 tracks across the glenoid. You then take your bone block, use this button system, load the button system. I typically use 2 buttons. I don't rely on 1 button. There's a large metal cannula which helps you to deliver the bone graft into the glenoid. So there are 2 buttons in the front, and then you load a button at the back and tie a knee knot, a knee sliding knot. You can do a sequential. You can make sure your graft is nice and flush with the subchondral bone, not necessarily with the cartilage, but with the subchondral bone. You can retension sequentially both the buttons, and then you can do a soft tissue Bankart repair over this bone graft. You can also do a Hill Sachs remplissage. So these are some of the images of the bone block. This is the post-op X-ray of the patient who we did a different system without implant, the bone block Saclage system. So these patients also recover their range of motion extremely well. So what is the algorithm that I follow now? If it's a contact athlete, I have a low threshold to do a Latarjet. Even in a subcritical bone loss, I would do a Latarjet in a contact athlete. If it's a subcritical bone loss between 12 to 18% with good tissue quality and a low demand patient, I would do a Bankart repair with a remplissage. If it's a poor tissue quality, high demand patient in subcritical range, I would do an arthroscopic iliac crest bone graft. And anybody, the minute it reaches around 20% in a regular population, I would consider a Latarjet. So my key points 2020. ICBG, that is bone grafting, and Latarjet give almost equivalent outcomes. Moroder and many other literature has shown this. What are the clear indication for ICBG or bone grafting in my practice? A failed open surgery, like you saw, subcritical bone loss, and the Hill Sachs if I want to do a remplissage, and the tissue quality is moderate, then I would repair it over the bone loss. Anybody with 25 to 30% bone loss or large Hill Sachs, I would then again shift to a iliac crest bone graft. So anywhere between 18% and 25%, Latarjet works well. The minute it is bigger than that, I would require a larger bone to provide the arc and make the Hill Sachs, which is off track, on track. And the trick is to ask your radiologist to incorporate the size of your Latarjet graft thickness, your coracoid graft thickness into your glenoid anteriorly, and see if the Hill Sachs can be made into an on track. So you can do that also, ask your radiologist to do that. And the indication is again for a bone block when the bone loss is more than 30%, what is called as a banana glenoid. And of course, when everything fails, especially Latarjet fails, again the bone block works in your favor. The Latarjet clear indications are when there is a poor tissue quality with subcritical bone loss. So if you have an overhead high demand individual and the tissue quality is very poor, even in a subcritical bone loss, the Latarjet works well compared to the bone grafting because your conjoint tendon compensates for that poor tissue quality and gives that sling effect in overhead abduction. You would do a Latarjet, as I told, between 20 to 25%. And if it's a failed arthroscopic Bankart repair, I prefer the Latarjet over the ICBG. I'm always itching to do the Latarjet for its excellent outcomes. Thank you.
Wonderful, Nagraj. So very clear-cut thought processes. As we have very high volume shoulder surgeons in our part of the world, we see a lot of this glenoid bone loss. And the point very well taken over here is that the ICBG has got two specific curves managing subcritical bone loss about 12 to about 12 to 30, 20%, and beyond 30%. 20 to 30 will undergo lethargy. So that's very clear-cut thought process over here and great explanation. I would like to ask all our people, anyone is doing, I know everyone is doing lethargy, but anyone doing ICBG or any kind of free bone block over here? Yeah, Clara?
Well, I do ICBG in revision cases. Also,
Right.
I consider it in epileptic patients because
Exactly.
I'm concerned with the convulsions and the traction of the conjoint tendon on the coracoid graft, which may cause this early failure and breakage of the screws.
True.
And to avoid this, I prefer the iliac crest.
Right. So the case Dr. Nagraj showed was an epileptic patient and he did a lethargy surgery. Will it be a contraindication in your scenario?
Repeat?
So Dr. Nagraj demonstrated his case number 1. It was an epileptic patient.
Yes.
And he did a lethargy surgery. He did an open lethargy surgery with 2 screws. Is that a contraindication in your scenario?
It's not a contraindication, it's a concern. I would consider discussing with the patient. I know that there's the donor side morbidity question, but what we saw was the patient then ended up not taking the medication, not controlling their epilepsy.
Right.
And maybe it would be more successful if I use the iliac crest. But this patient, it's a difficult population anyway, because since it's an autograft, if he takes the epileptic medication changes the metabolism of the bone. And so also this bone is very poor quality always. This is a difficult, it's when you introduce the epilepsy in this algorithm, it changes the logic.
Absolutely. Nagraj, what is your take home on patients with epilepsy and significant glenoid bone loss?
Yeah, I included that patient for inciting the discussion itself. So I agree with Clara. I do have a concern that if he has an epilepsy, the conjoint tendon contraction will rip off the whole construct. But fortunately, the lethargy, well done lethargy, if the bony union occurs, then you have hit a home run. Then there's no problem. The advantage of a lethargy over a bone block is that you've got the triple effect. You've got the conjoint tendon sling effect, you've got the capsular shift effect, and that is the reason why I prefer that whenever I feel that the patient is heavy demand like an epileptic. So at one end you've got a risk factor, but at another end you've got huge advantages also. Last point I'd like to mention is whatever cases I have followed up so far, the amount of osteolysis that I see after a bone block, a free bone block, is slightly higher than what we see in a traditional lethargy. So if there is a significant bone loss, I have got nothing else in a free bone block to rely on, unlike in a lethargy where there is a conjoint tendon sling and a soft tissue capsular shift.
True. Nice. Great.
Has anybody got experience with distal tibial allograft?
No, I don't.
We don't have that available. Yeah, we don't have that available in India.
In Europe, it's quite difficult to get fresh graft. Just to point out a couple of things about epilepsy and bone loss. When that is the case, first of all, control of the epilepsy is very important. Yes, we all know that. Having a surgical procedure will actually put a stress on the patient and might actually predispose them to a fit. So that's something that needs to be, without saying. I'm very concerned about metal and epilepsy because recurrence is not uncommon. So I prefer to use tapes when doing the lethargy. Whether doing it open or arthroscopic, I don't think it matters, as long as you use tapes and get good compression. And the only advantage for me of doing it arthroscopically is that I can actually gauge much better the capsular shift, as you were saying, when doing the procedure. And again, for bone blocks, in terms of osteolysis, rather than osteolysis, I prefer the term remodeling because as we've already seen from the evidence, what you get is basically bone that's not loaded will go away, and the bone that's loaded just restores the normal glenoid anatomy, which is exactly what you want. So at the end of the day, you achieve what you want from the procedure, as evidenced by the clinical results.
Perfect. Fantastic. That's a great thing. Thank you, Nagraj, for a great presentation. We move to our last talk. We have Dr. Gaurav Sharma, who happens to be my colleague at the Reliance Hospital. He's going to speak on failed Latarjet surgery, a patient with recurrent posterior instability following Latarjet surgery. Gaurav, all to you, Gaurav.
Yeah. Am I audible?
Yeah, Gaurav, you're good to go.
Yeah. So can everybody see my screen?
Yeah, Gaurav. Fine.
Yeah. Thanks a lot, everyone. I'm really privileged. Thanks a lot, Dr. Prasad, who's one of my mentors, and BOSTAA for giving me this opportunity. So I just quickly like to share one of my case, which I operated recently. So it's an open bone block procedure for a failed Latarjet. So a 37-year-old gentleman desk job, right hand dominant, sports level leisure, plays cricket as leisure, and presented with complaints of pain in right shoulder since about 1 week or so. And he felt a sudden jerk, that is an instability episode. It was a subluxation and not a complete dislocation, which happened while playing cricket. And so he had previous history of two shoulder surgeries. One was Bankart repair, which was done way back in 2013 when he was 24 years old. And he did quite well with that, but again had an instability episode in the form of dislocation, 4-5 dislocations, which led to around 19% of bone loss. So the surgeon then decided to do an arthroscopic Latarjet procedure when he was 29 years of age, which was done in 2017. So he did well with that, but again had an instability episode otherwise. So this image I could get from his after his first surgery. I mean, during the CT scan, which was done before his second surgery. So as you can see, there were 3 anchors which are put here. And this one is after the arthroscopic Latarjet. And this one is after injury. So one of the screws had backed out, as you can see. So now coming to the 2D CT scan here. As you can see, the graft had partly remodeled and united. And there was one screw which was lying outside. So this is that particular screw which is there. So based on the glenoid bone loss method, there was around 30% of the bone loss. So interestingly, we did a study on a cadaveric study in 2021, where we compared 2D and 3D models with the end-phase glenoid view, and we compared various methods, which were the linear methods and the Pico and the Barchelon methods. The Barchelon method is used quite frequently here. Both of them, as you all know, is a best fit circle method. So as per this particular method, we had a glenoid bone loss of a reported, which was of 30% here. So I decided to go ahead with an edenhebenite with the ICBG. So these were the 3D CT images. Now, treatment options and approach. So anybody with different thought process over here?
So basically, you have patient who has been operated twice.
Yes.
He has about 30% of anterior bone loss.
Yes, sir.
You don't expect a good soft tissue there.
Yeah.
And did he have an injury after the second surgery, after the Latarjet surgery?
Yes, that's what. So, so he mentioned that while he was bowling, while he was playing cricket, he felt a subluxation, but it wasn't a complete dislocation. So he did manage the pain for a week or so, and then he presented to me with just intermittent pain in abduction external rotation position.
So he's come to you for pain or for instability?
He came for pain primarily, and then I advised him some rest. And since the screws were backed out, on examination he did had mid-range apprehension positive.
Right. So he also had instability also.
Yes.
Great. Okay.
So, so this was his just pre-op. Right. And then these were the intra-op images. I could see the screw head. One screw was attached. I mean, the superior screw was intact, whereas the inferior screw had backed out, as everyone could see. This is the size of the bone graft, which I could get, and this one is the placement of the graft.
Right.
So I had used these buttons. So there were 2 buttons used, and he could, I mean, at 10 weeks follow up. So this is his range of movement. He had an ES score of around 65. It was the right side which was operated. Yeah.
Great. Great. Fantastic. Nice case. So what is the take-home message? So what are you trying to say? Anything specific you want to say?
So yeah, as Dr. Nagraj Shetty rightly mentioned that since the bone loss, anterior bone loss was more than was around 30% over a year, previous 2 surgeries. So my take was that I should go ahead with a bone block procedure, which is CBG, and so that it was a straightforward case actually.
Okay, you understand that when you're doing a Latarjet surgery, I have just answered because you did an open surgery.
Yeah.
Latarjet surgery, you're taking your coracoid towards the glenoid, So you're taking all your brachial plexus, all those kind of neurovascular bundle close. How difficult or easy was dissection over there?
So dissection, to be honest, was fairly straightforward, sir. It was just a little bit difficult for me to trace that particular screw which was lying just a little bit medial to the coracoid area, the previous graft, but so I could get it.
So you have to take out all the conjoint tendon, the coracoid, everything had to be dissected out.
Yeah, the remnants had to be, yes. I had to remove the fibrosis, and I could get
hold of it. Anyone in the house had this kind of a challenge, re-exploring the shoulder post Latarjet surgery, that will be an arthroscopic or an open surgery? Yeah, Nagraj?
So I have had a similar situation quite a few years back.
Right.
And we need to be very careful about.
Absolutely, yes.
We need to be very careful, obviously, about the structure because now there is a subclavicular split that has already been done during the previous Latarjet.
Right.
Sometimes there's a lot of scarring of the subscapular there. So I'd like to know from Gaurav. So that is one of the main advantages of the arthroscopic bone grafting. So you actually don't have to go near those dangerous areas. Of course, if there's a broken screw, etc., even that can be removed, and the extra-articular stuff can be just left the way it is. However, what I would like to know from Gaurav is how did you manage the subscapularis this time?
So I could see the fibrosis and the area of the subscapularis split, which was typically there at the 2/3, 1/3 junction. So I could trace a little bit of the conjoint tendon. I'm sorry, I don't have that picture available over here, the intraoperative picture, but yes, I could trace it a little bit, and then I just had to open and split it. So it was straightforward. Yes, definitely the capsule was kind of adhered. But this was the advantage, as you rightly mentioned, that since it was an arthroscopic Latarjet, the dissection wasn't too much difficult as it might have been had it been an open Latarjet.
Correct. Yes, so the ideal thing for a revision of an open Latarjet would be arthroscopic itself. And obviously, arthroscopic bone block is an advantage because you don't dissect in that area at all then.
Clara, had this patient come to you? You done the same thing? Something different?
Well, I think some of the lessons here are the bank Bankart repair a correct indication in the first place? And then was the Latarjet procedure done correctly? I think obviously the Bankart repair was not a good indication for this patient. And the failure of the Latarjet is not of the Latarjet itself, it's a technical failure. So then after this failed Latarjet, you have the option that was chosen by Gaurav. It's pretty straightforward, and it was very well executed. So I would have also done iliac crest bone graft at this point. But can you show me again the first when the first this is you have this image after the Bankart?
Yes, this is after the Bankart, after the first surgery.
Do you have before the Bankart? No.
No, I don't have, unfortunately, I don't have anything before the Bankart.
So but I think an issue here is also when you do this arthroscopic Latarjet and you use cannulated screws, they don't provide such a primary rigid fixation as non-cannulated screws, and probably this was part of the issue here, along with the fact that maybe the graft was fixed a little bit too high. So I think this is important to discuss, and this is one of the reasons why, as I said before, you have to be a high volume Latarjet surgeon to avoid these pitfalls. And this is the rationale behind the French school not measuring the anterior glenoid defects systematically and opting to use the Latarjet systematically, because this way they have an amazing learning curve and they avoid all these pitfalls and they have a success rate that's very high. But if you don't follow this school and you just use the Latarjet for patients with more than 20% of anterior glenoid bone loss, you end up probably doing too few Latarjets, and then you end up doing these mistakes that need a revision to an iliac crest.
Okay. And my question to the house: what's your take, or what's your measurement technique for the glenoid bone loss? It's open to everybody. Yeah.
Guys, do you want to, so that I don't monopolize this?
Okay, so if you're referring to this case in particular, I would have chosen the same option to put a bone block to augment the glenoid. I would have done it arthroscopically because I'm more comfortable than open, and I would have assessed the soft tissue at that stage, and had there been any left, try and reconstruct the anterior capsule if possible. Now, a question for you, Clara, is in that situation with anterior capsule deficient, would you consider doing a DAS as well as the bone block?
Yes, it's called a badass.
A badass, yes.
It was described by Achilles Boutsiadis, and he does this a lot, particularly in epileptic patients. He uses a bone block and then he does the DAS on top of it. Of course, it would be another solution to make sure that this patient doesn't have a third surgery. So it's a very nice idea, Carlos.
Great.
Just a quick question to Dr. Nagraj in terms of his management of subcritical bone loss with off-track lesion. Would you change practice listening to Clara? Would you use more of a DAS in your practice rather than doing a Latarjet?
So I think the indications for DAS are never replaceable to a Latarjet. DAS, in my understanding, has got its own clear indications. There should be minimal to no bone loss, and the tissue quality should be very poor. In a primary situation, that's the indication. In a revision situation, again, failed Bankart repair with minimal bone loss. For me, these are the two classic indications for a DAS. If the tissue quality is good, I would rely more on soft tissue repair. If there is bone loss, I would rather compensate with bone there. I don't think a soft tissue like a biceps can compensate for bone loss. I don't mind Clara, clarifying these points.
All right. My one last question. Any take on differentiating between any difference in inserting the screws, arthroscopic lattice versus open lattice? Do you all have observed that the arthroscopic lattice the screws are a little bit more superior as compared to the open technique? For not a high volume surgeon, of course.
So I think I'll just go with a few points that I have understood over the years. We need to understand that when we are dealing with the latagia anteriorly, we are not able to have a three-dimensional perspective. We are dealing with a scapula which is not under your control. We don't know about the version of the glenoid. So the best thing that you can do, which I follow, is I use an offset guide, which is at a fixed alpha angle, which gives me some clarity as to what is the trajectory of my screw. So that I just do an open latagia. I don't do an arthroscopic latagia for this reason, because I like to keep some control with an offset guide onto the cartilage, which gives me the ability to drill. Now, if I have to do a latagia, I would rather do the button technique, because there you are drilling from posteriorly, the Pascal-Bulow technique. So a jig comes parallel to the glenoid, and then you're absolutely sure that your track is perfect. But if you're drilling from front in an arthroscopy, when you're visualizing from the lateral portal, you can never be sure of the trajectory because you don't have the three-dimensional orientation, and the chances of you going wrong are very high.
Carlos, you got any view on that?
Yes, I would agree with that. And I use a similar technique. I use the Arthrex cerclage, the bone block cerclage technique for the latages. It's an extension of the bone blocks, really. If you're drilling from the back, you're visualizing the front. You're looking from the front. Doing an anterior shoulder arthroscopy, you can actually be pretty sure of where the tunnels are. You can then fashion your block to fit that. And if you leave it a little bit prominent, which is not uncommon, you can then actually reshape it towards the end of the procedure. All of those, for me, are advantages of doing it arthroscopically. Again, I don't do a lot of open surgery, so for me, I'm comfortable doing it arthroscopically. But again, if you are doing it open, there's no reason why you couldn't use tapes instead of screws, which actually changes quite a lot the complication profile, because many of them, a big part of the complications are related to metalwork.
So, Carlos, I completely agreed with you that circlage techniques are technically more easy. They're a little easy to do. They have lesser metal complications. But what about the osteosynthesis? Is that a concern with circlage? Only circlage?
No, actually, from the point of view of biomechanical studies, you get at least 100 newtons of compression there, which and it's much more homogeneous. It's across the band, so it's not in 2 points where the screws are. So biomechanically, I don't think it makes a huge difference because at the end of the day, clinically, we are seeing union in a vast proportion of the cases. So
perfect. Great. So it was, I think so. We had good 6 talks covering the entire spectrum of shoulder instability, right from soft tissue till the failed latagia. I would like to thank all the speakers, all the international Indian speakers over here. It was a great interacting with BOSTAA and BOS, and there is a lot of take-home messages for all the shoulder surgeons over here. Thank you very much. Yeah, Ravi, you want to put some concluding remark?
No, thank you very much again for Bombay Orthopaedic Society and collaboration with BOSTAA. I can only see this collaboration getting stronger and stronger over the period. We have a great panel of expertise who can share knowledge and learn from the experience you guys have across the continent as well. So I'm thankful to everybody. Thank you.
Thank you, everyone.
Yeah.
Thank you.
Before we,
On
before we
behalf
move, Gaurav, before we move on to the official vote of thanks,
Yes,
I think
please.
this has been one of the most involved webinars from the entire series that I have seen. It's almost 11 here, and I think you all were really so deeply focused on expertise, on bringing out every aspect of the challenge. And what I really enjoyed going through is that the skills that you all possess are with a lot of deep thought. And at the end of it, I think it's a very holistic approach which you all have presented today. So that's wonderful to see. And Gaurav will do he's our webmaster for the Bombay Orthopedic Society. So he'll do the official vote of thanks now, including our sponsors and Ortho TV.
All right. So thanks a lot, everyone. We are really happy and hope to have more interaction with BOSTAA. And thanks a lot, Dr. Prasad Bhagunde, for bringing this here, and Dr. Ravi Bagre. And I, on behalf of Bombay Orthopedic Society, would like to thank everybody over here, and also our partner, Torrent Pharmaceuticals, for helping us in this webinar. Thank you, everyone.
And to Ortho TV, who's always been
Yes,
there
yes,
to relay this and make them more popular. Thank you.
Thank you.
Thank you.
Thanks, everybody.
Thanks a
Good
lot.
day.
Good night.
Thanks, Chris. Thanks, Carl.
Bye. Thanks so much.
Bye.
Thank you very much.